Muy buenos días.
Good morning. Welcome to Uruguay. It's a pleasure to receive you in this regional forum
De presentación de la Alianza para la Atención
representing the Alliance for Primary Healthcare in the Americas. My name is Ernesto Vascolo. I'm the head of the Primary Healthcare Unit and Integrated Health Services of PAHO, and together with the team of our unit and ASE, we will be with you these 3 days. We want to especially thank the authorities that are with us today, Minister Karina Rando, the vice ministers that are with us, the director of PAHO, Salva Barbosa, the representatives of the World Bank, of the Inter-American Development Bank, and World Health Organization, UNICEF, CAFA, USAID, and other international organizations that are with us today. And very especially, we wanted to greet the delegations of 36 countries in our region that arrived in Montevideo for this event. Our most sincere thanks. Before we start, let me share with you 3 housekeeping messages. First of all, logistics. We have simultaneous interpretation into Spanish, English, Portuguese, and French, both in this plenary session that we call Room A, and in the second floor, Room B. That's the way we'll call them this week. So make sure that you have your simultaneous interpretation headsets so that they are available outside. And we have a team to support this event, and they will be fully available for you. And so you can see them. They have the blue badges, but you can also see them at the counter. So we are already transmitting this. We are streaming this into the 4 languages and in the channel, in the PAHO channel. And we invite you to share those links with your colleagues. Second thing, one of the aspects of the agenda today, you may be aware that we have updated the agenda these last years to show the changes of this official launching of the alliance. Instead of being at the first thing in the morning, it will be at noon. The agendas are in the screens and the corridors and in the PAHO, the website. And third, I would like to take a few minutes to share some general characteristics in our agenda, especially the working dynamics that will have these 3 very intensive days. We'll have 2 types of sessions. Sessions that are plenary, that will take place in this room and in this hall, and the panel sessions that will be in parallel, both in this room A and on the second floor. You can have access to them with the elevators in the middle of the building or the staircase. You may have noticed that we have a limitation. We will be we'll have no room enough here in this audience. So in the plenary sessions, we will do streaming to the second floor if there's no room for you in this room. And the second type of sessions that we'll have is panels. Tuesday and Wednesday will work in the 2 rooms, working in parallel. And there, the option to participate in one or panel or the other will depend on your own interests. The forum will have 3 different modalities. Our sessions will include discussion panels. Some will be conferences with commentators, and others will be presenting experiences. And the third day, on On Wednesday, we'll have working workshops where we will be discussing experiences and discussion with the countries participating those days. And finally, let me remind you that after the regional forum, after these 3 days, we'll have the national forum, where we will receive some international guests that have confirmed their participation. So, starting the work of a regional forum, we want to invite Minister Dr. Karina Rando, who will share the welcome words. Thank you.
Buenos días.
Good morning. Apparently today we have a beautiful day ahead, starting these very promising meetings. The director of Pan American Health Organization, Jarbas Barbosa da Silva, national authorities, representatives of international agencies, ministers, deputy ministers, guests coming from sister countries, and representatives of healthcare ministries of health, deans of public and private universities of our country, experts of international agencies, directors of the Ministry of Health, Deputy Secretary of the Ministry of Health, representatives of the health sector in the private and public sector. Ladies and gentlemen, welcome to Uruguay. Primary healthcare is a strategy whose essence is the values of equity and social solidarity, as well as the right of all human beings to enjoy the maximum degree of health possible, with no distinctions of race, political, economic, or social status. We commit to the population we serve.
In order to respond to this population's profile of health needs with a comprehensive model emphasizing health promotion and disease prevention, key is that primary health care approaches health and disease in a proactive manner. It does not wait passively for the spontaneous demand, but it tries to detect early those processes that determine the creation or the appearance of disease, that is primary prevention, and also through programmed care, it tries to prevent complications, secondary and tertiary prevention of those pathologies that are part of the lives of people. Primary health care is not a level of complexity of this health services system. It's a strategy that does emphasize the first level of care, but also encompasses different levels so as to aspire to universal health coverage. Primary health care is the most inclusive, equitable, cost-effective, and effective approach that improves the physical and mental health of people as well as their social well-being. There are ever more proofs in the world of its wide effect of invested in primary health care, particularly in times of crisis such as the recent COVID-19 pandemic. Objectives of this regional forum are to launch the alliance in order to support those countries that are expanding their primary health care at the national, subnational, and local levels, to exchange experiences and good practices in innovation and implementation of primary health care, to exchange experiences and good practices in funding of health and financial management for the transformation of the health system based on primary health care, to share initiatives and tools of PAHO, of WHO, the World Bank, the IDB, in order to develop and contribute innovation, investment, and implementation of primary health care, and to establish a network, a multidisciplinary network of experts to support national, subnational, and local actions, and to strengthen cooperation amongst countries. We know that these objectives are very ambitious, but I trust that our joint work of national and international experts, decision makers, academicians, civil society, and all actors in the health systems who are present here will be fruitful. I hope you enjoy this forum and welcome to Uruguay. Hello. Thank you very much for your words, Mrs. Minister. Now, before going to the first session of the day, we want to invite Dr. James Fitzgerald, head of the PAHO Health Systems and Services Department, to share some words with us.
Muy buenos días. Good morning. Idiomas oficiales de la OPS que representa a todos los países que están presentes en la sala. Realmente por su presencia aquí en Uruguay. My name is James.
Mi nombre es James Fitzgerald, soy director del Departamento de Sistemas y Servicios de Salud en la OPS y realmente estoy feliz de estar aquí.
Work with you and share with you during these 3 days the experiences of countries in the Americas and really a health sector transformation based on primary health care. My thanks in particular to Minister Rando for her welcoming words y también al gobierno de Uruguay.
And also to the Uruguayan government for receiving us. This has been a pleasure to be here in this beautiful city and to take advantage of this time with you in Uruguay. To all workers, healthcare workers in Uruguay, I wanted to acknowledge them and thank you for all that you have done in the past difficult years because of the pandemic.
To our director, Dr. Jarbas Barbosa, for being here with us and for sharing in this journey. Dr. Barbosa has prioritized primary health care and is really elevating this agenda as director of the Pan American Health Organization as a strategic component of the recovery of pandemic preparedness and as a driver for greater equity in health in the Americas. I want to also recognize the presence of Dr. Jaime Savreda, the Director of Human Development for Latin America and the Caribbean, and also Pablo Ibarran, the Head of Social Protection and Health Division of the IDB, of the Inter-American Development Bank, and of course the technical teams and coordinators of the Office of the Latin America and the Caribbean from the respective brands. We built an important partnership during the pandemic with the regional institutions, the regional financing institutions, to really scale capacity and response in COVID-19. And we've continued to work very closely with the IDB and the World Bank and other financing institutions to really accelerate transformation, to build a strong foundation of primary health care now in the Americas. A heartfelt welcome also to our colleagues from WHO Geneva who are here with us from the Special Program on Primary Health Care and the Alliance for Health Policy and Systems Research. Also welcome to CAF, to UNICEF, to USAID, the OECD, WONCA, who are all with us, and to all the countries, of course. Really thank you for coming and spending this time with us. We know you have a very complex and busy agenda, but I think it's really been a pleasure to receive you here and to be able to share these days with you. Finally, to our technical directors at PAHO and the technical teams that have traveled from all over the region. We have a wealth of experience in this room across all technical areas within PAHO, so please avail of meetings with them during these days. I think we've really convened a great group of experts regionally, globally in this room so that we can work together in strengthening primary health care. A final thanks to Dr. Hernan Montenegro and the team from Uruguay who have worked arduously also in supporting the organization of this meeting. Colleagues, we are all here because we are champions for primary health care. Primary health care is a global movement that commenced with the Declaration of Alma Ata in 1978, and it has been, as Minister Rando so clearly put, at the heart of global, regional, national and local public health since then. The region of the Americas lost one of its greatest champions in primary health care last Friday with the passing of Dr. Carissa Etienne, the Director Emeritus of the Pan American Health Organization and the former Director of PAHO, the Assistant Director General of WHO in Health Systems, and the Director of Primary Health Care in her home country in Dominica. In 2005, as Assistant Director of PAHO, Dr. Etienne launched a movement that commenced actually here in Uruguay, that grew regionally, and then transcended globally on the renewal of primary health care. She was never tiring in her conviction that the primary health care approach was the way forward to achieve universal access to health and universal health coverage. Please, colleagues, let us stand for a moment of silence in honor of Dr. Etienne. Thank you very much. Let me now provide some additional background on the International Forum on Primary Health Care and the reason that we're all here actually in Montevideo. It's been some time since we've been able to convene countries around issues of health systems, around policy dialogue and the need for really expanding access to comprehensive, integrated, quality healthcare based on primary health care. So what we've done is really worked with you, with Uruguay, with our partners on building an agenda, as Ernesto very nicely put it, to look at the shared experiences of countries and to identify some of the key areas of work around the issues of innovation, implementation and investment in primary health care. Over the next 3 days, we do aim then to discuss the international practices in health policy, health financing and financial management to support primary health care, including those issues around intersectoral action between health, finance, and social protection in health. Later this morning, we will launch the Alliance for Primary Health Care as a collaborative platform to support our countries in the expansion of primary health care at the national, subnational, and local levels, focusing on really addressing those critical barriers to access care and expanding coverage in health services at the local level. We also aim to share important initiatives with you and tools from the organizations that are participating in the Alliance to support the expansion, investment, and implementation of primary health care in countries. As Ernesto also mentioned, this will be followed by the National Forum on Primary Health Care, and I think it's important to note that approximately 50 of you will be staying for that event and having the opportunity to visit local health centers, primary health care, to see how Uruguay has been able to manage to structure or organize its primary health care, its system based on primary health care, ensuring equity and access to health services at the local level. So essentially, this meeting brings us together to promote cooperation between us, between organizations, but most importantly between countries, and to establish those multidisciplinary networks of experience and expertise that we really require to accelerate the recuperation of lost public health gains, moving towards universal access to health and universal health coverage. We are joining forces this week also with the IDB, the World Bank, to launch this Alliance for Primary Health Care, to really facilitate coordinated action in Latin America and Caribbean to strengthen the foundations of primary health care as a core foundation of health systems. The objectives of this alliance are fivefold. Firstly, to support the development and expansion of health systems based on primary health care approach, focusing on issues around resilience within the health sector, promoting the principles of universal access to health and universal health coverage. This will really focus on ensuring alignment of policy and operational frameworks to strengthen health systems based on primary health care. Secondly, to look at innovation, to accelerate the innovations within the health sector and the innovative approaches around primary health care. Thirdly, to foster coordination and coherence between our organizations and among regional primary healthcare initiatives that will limit and address issues of fragmentation in our action, addressing equity and effectiveness priorities. Fourthly, to leverage finance and action from countries, both regionally and globally, and including from the private sector as appropriate, promoting increased coordination in financing for health to strengthen and expand primary health care. And most importantly, to accelerate our joint action around a critical issue around the availability and quality of the regional health workforce. We are already working around some of the institutional arrangements to support the Alliance for Primary Health Care. We will look at how we can essentially coordinate policy dialogue, establish mechanisms for the analysis of national needs and investment plans leading to joint supportive action in countries. We look forward to leveraging joint technical and planning instruments for supporting countries and expanding the existing work and arrangements that promote dialogue, this important dialogue that is so necessary between health and the finance sectors. And finally, we will be working to promote increased and coordinated financing for health in countries with most especially increased financing for primary health care. So in conclusion, let me thank once again Uruguay for really receiving and hosting us this week. We really hope that you benefit from this important forum, benefit from the work of this building alliance, and please engage with us. We're here for you. Engage with us with the experts that are here, with the countries that are here, on social media, and share your experiences and connect so we can learn from one another and accelerate our actions moving forward. Thank you very much.
Muchas gracias, James.
Thank you, James. Hence, we start the first session of our work. I want to remind you of these three pillars. Investment, that means more public resources with our solidarity concept and prioritizing the first level of care. Innovation, which implies accelerating the processes for the implementation of APS policies, integrated care, the approach of social determinants. Third, implementation, which implies access, equity, territory. These three pillars will be structuring our 3 days of work. Now, we are going to start a higher level dialogue on the importance of one of the topics that are part of the first pillar, the strategies of innovation and integration and implementation to improve the healthcare services. And let me invite the chair, Elena Legido Quigley, it's an honor, Elena, to have us among us. She's a professor and she's the chair of health systems in the Imperial College of the George Institute for Global Health, St. George's in the UK. She has a vast experience in vast regions of the world, Europe, Sub-Saharan Africa, Southeast Asia, and Latin America. She has significantly contributed to topics such as global health, focusing on issues such as healthcare system resilience and the challenges of healthcare faced by migrants and refugees. Her most recent work approached critical topics such as the preparedness against pandemics and the issues related to healthcare globally. Helena. Thank you, Ernesto, for your presentation. Welcome, ladies and gentlemen. Welcome to this regional forum. For me, it's an honor to be chairing this first session. Thank you, Madam Minister. And Deputy Secretary. You explained that you called it Subsecretario in Uruguay. So thank you for being present. And as Ernesto says, I come from the Imperial College in the UK, and we have a vast collaboration with Uruguay and with the WHO agency here in Uruguay. We have worked how to conduct research at a national, international level, and to how we can collaborate with different agencies. But today, my role is to chair this session. I want to introduce the people that will be in charge of the debate, and then, so I'm going to invite you to join us here so that we can start with questions. And my task is a bit complicated because I think that you all know each other, but I wanted to introduce you formally. And what I'll try to do is to introduce some characteristics that they have. And I've realized that the three of them are doctors. They have PhDs, and the three of them devote time to research. So let's start with Dr. Jarbas Barbosa. You know that he's the PAHO director. He's been the director since September 2022, and before that, he was in charge of directing the pandemic activities in the region. Dr. Jarbas Barbosa is from Brazil. He was a deputy minister since 2006, and he has a vast experience as director of Anvisa in Brazil, where he modernized the regulation of medications, not just in his country, but in the region and globally. The part that you may ignore is that he's also in charge of research, and the last papers that I saw published in The Lancet, he published one on mental health and another one on how to fight against infectious diseases in the region. He did his PhD in public health at the University of Campinas, Sao Paulo. Our second speaker is Dr. Jaime Saavedra, Director of Human Development for Latin America and the Caribbean of the World Bank. In the past, he led a global practice of education of that institution, and he was a global director of Global Reduction of Poverty and Equity. Dr. Saavedra was Minister of Education in Peru from 2013 to 2016, and he has led many works in different institutions on poverty and inequality, on unemployment and labor markets. And he collaborates in the Catholic University in Peru and in the University of Toronto. Then we have Dr. Pablo Ibarran, Director of IDB. He joined IDB 20 years ago in 2005, where he was in charge of several activities. Economist of strategic planning assessment, aging agenda, and maybe the most important is evaluating health programs, among other areas. In addition, Dr. Ibarra also participated in the Ministry of Finances in his homeland country in Mexico, and he's a doctor of economy in Berkeley University, and he also investigated in Bonn in Germany. So after welcoming our three speakers, we'll start with the questions. Can you hear me well? So, we are going to organize this to make it nimble. So we're going to start with a question for all of you, and after that I'll adjust questions individually, and then finally we'll wrap up with other general questions. So, Dr. Barbosa. Well, first of all, this question is for all of you, actually. We know that today we are launching the Alliance for Primary Health Care in the Americas with these three agencies. And so that we can understand how this process will work, we'd like to know, why do you get together working in this new alliance, and how do you think that this new alliance may help the countries strengthen the primary healthcare approach? We can start with you. Thank you, Doctor. I want to thank the government of Uruguay for so kindly hosting this event and receiving us to launch this initiative that, in our view, is absolutely critical to face the inequality and access disparity that we have in Latin America. Unfortunately, in our region, the access to adequate health care services, unfortunately, still depend on your parents or your family's income and the color of your skin, and it depends on where you live. Unfortunately, Latin America has huge inequalities, and it's a region where we don't cover the healthcare needs and services of all Latin Americans and Caribbeans. And in that regard, the need to increase our efficiency, quality, and effectiveness of services is absolutely urgent. And as the minister said, primary healthcare is one of the most effective ways we can start solving these huge problems of inequality of access. It's primary healthcare that focuses citizens, saves lives and money. So in that context, and in a context where we recognize many challenges in addition to the well-known, that is the point of entry to an integrated and more efficient system. In addition to that, we need to be resilient to respond to future emergencies. We have to expand the role so that we can prevent and manage many of the potential shocks we are likely to face. So it is in that context that it is absolutely critical to have this alliance, first of all, with IADB and with PAHO. I would say that because of three big reasons. The first reason is that it's absolutely essential to have a coordinated work of all the multilateral agencies to give a more effective support to governments. In the end, it's governments that will define the plans of investment through which it will be possible to expand the systems with quality. So the governments have to define that. Multilateral agencies can then disseminate that. But it is absolutely crucial for us to coordinate that work so that all the institutions, agencies that provide funding or technical systems may work in a complementary manner and synergically so as to be more effective as we work. That's a core thing. And you can say, well, some agencies may work on some issues, other different territories, but making sure we avoid duplications or gaps, but we have a better coordination and more synergism. That's a core thing. The second core thing is that unfortunately in our region we still lack understanding by the population of a real understanding of the problems we have. Unfortunately, in many of our countries, the quality of healthcare services is not good enough, and people say, well, it's always been like that, so what can we do about it? So there are huge inequalities within and between the countries. So we have to do a lot of advocacy, be very proactive, putting health and putting primary health care in the debate of public policy. It can't be an issue limited to this community, to this tribe. We have to make sure that the rest of the community will understand public health care policy, and that the parliaments and ministries of finances, all the agencies, all the stakeholders may understand the size of our challenge and the urgency of this challenge. So we can't leave this to just the group that's working on primary health care, and we need to make sure that the community and society are aware of our challenges. And finally, James mentioned several issues that are critical in this alliance, but I want to emphasize the issue of human capital, the people working in health. There are many, many topics that are important if we want to improve the quality of work, management, infrastructure, teams, equipment. But unfortunately, the quality of service depends on the interaction between the people who need the service and the people who need support and those that provide services. And so that we should invest more in developing a better labor force and investment in health is absolutely essential if we want to define the quality of the services we provide. Thank you. Thank you, Helena. Welcome. Well, at lunchtime, I'm going to greet you properly, but I want to thank Dr. Karina Rando, the Ministry of Health in Uruguay, for receiving us so warmly here in the country, in Uruguay. So I think that Jaime already mentioned some important things. First of all, we need to recognize that we are the most unequal region in the world and in all our countries. Despite all the progress made in recent decades, the pandemic showed us how we need to change healthcare services in many aspects, not just being better prepared with surveillance and early detection and response, but we need to have healthcare systems that are more resilient, because the pandemic underscored many fragilities that we still have and many gaps in the healthcare system. It emphasized all the priority health issues. In some countries, the maternal mortality rate doubled, as if we had gone back 20 years in just 1 year. We had about 20% children that were not vaccinated. And we saw the worsening of a tendency that we had already seen in 2013, 2014, of a reduction of coverage of routine immunization against polio and measles and other diseases.
Many people with diabetes and hypertension stopped receiving diagnosis or access to drugs. Many people with cancers, all the rates of TB detection went down. So beyond the economic environment that was difficult for countries because of the formality of economics, poverty, and other factors, despite all the efforts, Latin America was the center of the pandemic for some months. So I believe this has underlined the importance of acting in a more coordinated fashion, as Jaime mentioned, that institutions, regional institutions, and the bank, which is global but has a strong presence in the region, and IDB, with which we have a very strong alliance in some health issues, could work more coordinated. I'm sure that banks know more than I about figures, but in our estimate, the countries in the region of Latin America and the Caribbean mobilized in 2022-23, $2.2 million loans in order to strengthen their health systems, and also as a response to so many problems and fragilities that the pandemic showed. That created an opportunity to attract attention towards the health system. We never had so many presidents and prime ministers who were directly in charge of leading processes, supporting their health ministers, ministers of different ministries working jointly. That created an opportunity, I believe, to call our attention to the need to strengthen health systems, not just to respond to a future pandemic or public health emergency, which will occur. We don't know when or how seriously, but it will occur, but also to go to some of our fundamental structural problems in health systems and to strengthen primary health care is one of the first ones. We believe there is an important effort of countries to strengthen their hospital network, to modernize it, to equip it, which is very important. But if we do not make the same investment in primary care, the system will be unbalanced and we will have far less capacity to improve the quality of our expenditure on health. If we go on diagnosing and treating diabetics when they get a renal complication or a blindness or a foot amputation, or a hypertensive person when there is a severe case of cardiovascular disease or ACV, well, that cannot happen any longer. So I believe that in order to have a balanced system that may even guarantee better and more access to people, because even in countries where the right to health is guaranteed in laws, when we review, and we have data of many countries in the region, social barriers, cultural barriers, economic barriers, and others are still not allowing everybody in the region to have the access that they should have to health systems. So primary health care, I believe, is key, because renewed, strengthened primary care that is not just the original primary care of 45 years ago, which was a revolution indeed in Almata, but it was really centered on an epidemiological profile of that time. Nowadays, we have to think of primary health care with the capacity to have health promotion, surveillance, response to outbreaks, and primary care that may respond to that complex, wide epidemiological profile that we have, that may help reduce pregnancies in adolescents. Our rates are shameful in many of our countries in the region, that may contribute to reduce preventable death with non-communicable diseases. I believe that we shall need an important investment to improve the whole infrastructure for human resources as well in primary care, which is key. Last week we had a meeting that we hold every year of all the PAHO country office directors and all the directors in Washington. And on some days we invited some ministers who could come to PAHO and tell us their priorities for the coming period. And Minister Rando was one of our guests, and she mentioned human resources for primary health care, which is not just a problem in Uruguay. It's one of the main problems in the whole region, and also the issue of how to better take advantage of some of the innovations that the pandemic accelerated, the use of digital health, telehealth, to really take better advantage of those to strengthen the system. Finally, we already have a history of joint work with the IDB, for instance. In March, if I'm not mistaken, I was with its president on the IDB headquarters to celebrate 5 years alliance between PAHO and IDB on strengthening of health information systems that would allow the countries in the region to mobilize more than $900 million in bank loans to strengthen their information systems. And we are now also adding the issue of digital transformation of health. So we have a good history, and we also think that with the bank, we shall use the same tool that we have used in Panama and the Dominican Republic. We now have an alliance with the World Bank. So I believe there is this joint will, this joint understanding that is the basis for a good alliance to have the same objective and to coordinate our actions. Thank you very much. Good morning. First of all, my thanks to the Minister of Health of Uruguay and the Secretary of Health, and also my acknowledgement to Dr. Barbosa for this initiative of creating this alliance. After he took office, we were talking already about the importance of creating this alliance. The idea here is to make sure that the sum is more than the addition of its parts. The need to concentrate efforts on this was mentioned here, how the pandemic showed many failures of the health systems, and people had been requiring it from before, because before the pandemic there were many social protests in many countries in the country, from Sao Paulo to the Ecuador, Colombia, many countries. People were protesting because they did not have access to good quality healthcare systems, to education, so that malaise was interrupted because of the pandemic, but it showed those failures. And we are the region that was the center for several months with a death excess that was very important, and several of our countries suffered it. There is a clear need. It is important to think of the size of this work and the Alliance's success, to acknowledge the strengths and differences among our institutions. It's important to have the specialized agency in health, which is the one that really sets many of the guidelines, and also the global experience of the World Bank and the IDB experience in the implementation, operationalization of many of these projects. So there is plenty of room. We have worked. We, of course, have to improve our coordination systems. We have worked successfully, as was mentioned by Dr. Barbosa, in several subjects with PAHO and with the World Bank. And right now, we have also formalized an agreement on digital transformation and education. So health is something that we're also naturally working on and coordinating in several countries. We are working jointly, supporting governments, and I believe that is a very important mechanism. Collaboration is not new. It's necessary. It's a way to respond to countries. Something that we all have together is that we are three institutions that are owned by the countries. In the IDB, the majority of the directory board is in the countries in the region. So we work for the countries. Our priorities are the countries' priorities. So it's important to build this alliance based on trust, on evidence, and on an opening to really achieve the objectives, which is to increase investment and what has been said before. I believe that trust and to acknowledge the limitations of health systems so far and the urgency that countries mentioned to advance. Thank you very much, Dr. Ivanan. We have heard many important areas: the importance of collaboration to avoid duplications, the importance of countries taking the initiative. It was also very interesting, the idea that you have to create awareness of the importance of primary health care and the importance of human capital. And the most positive thing is the idea that the pandemic was awful for all countries in the world, but we have to see it as an opportunity to improve and strengthen primary health care. Proceeding with these reflections, Dr. Barbosa, now I wanted to ask you something more specific. PAHO has two crucial initiatives: the elimination of diseases and also to have better care for non-communicable diseases. I wanted to ask your opinion on how the three institutions may collaborate to improve your two initiatives. Thank you, Elena. We are working with countries and supporting them in many issues, from the strengthening of their capacity to produce drugs, vaccines, medical inputs, and also subjects such as health promotion, environmental impact, and others. But right now, during the Directive Council, that was at the end of September, we relaunched the elimination initiative. Elimination of diseases was approved by countries in our Directive Council of 2019, and then the pandemic arrived, and all efforts of countries in PAHO were focused on pandemic response. So we relaunched that initiative now, which is an ambitious one, to do away with 31 diseases and conditions that are different, so that we may advance in health and also in equity. Because when we see those diseases, they are all concentrated in those populations that are most vulnerable. And so they start this vicious cycle. The poorest people get sicker, and when they are sick, they become poorer. So I believe it is important to take advantage of this alliance to strengthen primary health care, so that when we think of cervix cancer, for instance, which is the second cause of death of women in the region, but when we divide the data and we go to rural areas, poor people in cities, it is still the first cause of death for women and in those groups. And we already have tools, first of all, to protect future generations with the new vaccines, and vaccines that the countries may use through the rotatory fund, Bajo Rotatory Fund. For instance, for next year, we are providing BPH vaccines for $2.9 with a pre-qualified producer. That is a great reduction, because up to this year, the price was around $9 and something. But we also have the possibility today of enlarging everything with the introduction of new technologies in primary care, for instance, detection of HIV with PCR tests, training teams to carry out treatment of BPH lesions. When we consider TB and HIV, there is a lot to be done for HIV, for instance. And in the World Day on HIV in Latin America, we only have 100,000 people using PrEP, which is the most effective tool to decrease transmission in a vulnerable group of high prevalence. Prevalence is average 0.0 something in the country, 0.15 or 18, but in young gay men, it's 10, 11% prevalence. So if we do not have a change to introduce these new technologies more quickly, we shall not achieve elimination. And to be close to the community, identifying cultural aspects, social aspects, I believe primary health care is the main platform we have for that initiative of doing away with disease. For non-communicable diseases,
the data change from one country to the other, but as an average, out of 100 people with hypertension, and I mention hypertension because it's the leading cause of death in all the Americas, around Canada, Chile, Argentina. Hypertension is the leading cause of death. Out of 100 people with hypertension, only 50 are aware of their condition, and only 25 have it under control. That is, we won't reduce the 34% deaths, preventable and premature deaths in the region for non-communicable diseases, unless we have a primary health care that is well trained and equipped with a vast pack, so that the people with hypertension may receive care. And the same applies to diabetes and the screening of many types of cancer. Many countries are already making progress in that direction, and what we want to support with training, technical guidelines, and identifying opportunities, and offering medical equipment with Bajo's strategic fund to accelerate that space. So the idea is not to wait until 2030 to have the entire system of primary health care ready to respond to non-communicable diseases, but we should have it ready by 2025 so that we can speed up the reduction of preventable deaths. So I think that this alliance plays a key role for the success of the two initiatives. Thank you, Dr. Barbosa. Now, going on with the World Bank, Dr. Saavedra. Is it true that the World Bank was cutting edge in the study and the construction of resilience in healthcare systems. And likewise, as a result of the pandemic, you created the Pandemic Fund. It's very important for this alliance to better understand how to align for healthcare with the work of the World Bank through the fund, and also through the increase of investments and strengthening of primary healthcare. What's your comment about that, about how to fund it? Well, let me mention three issues, three topics that show the alignment of this alliance with the bank's work. And let me mention three things. First of all, alignment is clear because precisely the bank's strategy to improve the resilience of healthcare systems is to invest more accelerated and as a priority to invest in health in a country, in a region that has huge inequalities of opportunities. It's a great challenge for development. We already mentioned it. Primary health care is a key element in a region that, in addition, let me mention a couple of figures. We spend per person 1/5 as an average, 1/5 of OECD, and within Latin America there are huge variations. So we are not investing enough, and we are not investing in an equitable manner, and that inequality of investment is reflected in the huge out-of-the-pocket spending in many of our countries. As an average, it accounts for 30% or even exceeding 30% in some countries. So in that regard, we see, as the World Bank, we are fully convinced that primary health care is critical to solve these issues. We need an effective and quality service that is perceived by people as being attractive and useful. So, first of all, our strategy places primary health care in the center of an integrated healthcare. Second, we will make the most of synergisms with the fund for pandemics, because much of the investment that needs to be done is the same for preparedness against catastrophic events. Primary health care is absolutely crucial if we are to experience a new event, for surveillance, access to immediate work and prevention in managing cases and supporting mental health of people, and in general, given the closeness to the community, that is essential to prevent, detect, and manage pandemics. So in that regard, it is not complicated to justify much of the work that can be done through this alliance as part of the investment in the Fund for Pandemics. And third, the bank has defined its what to do to eliminate extreme poverty, and now it's the same, but later on we'll have an opportunity to talk about climate change. But in that redefinition of the mission of the bank, we are finding some core elements that are absolutely critical for our work. And I mentioned three: scale, impact, and alliances, so that we can move faster in those objectives. As at the World Bank, we ensure that we are working at a scale. We don't care about a small territory or a small center or a school, but we care about systems. As multilateral agencies, we need to help countries to repropose the systems as a whole, so as to quickly, as Jarva said, to reach quickly, as not to say, well, these are complicated structural problems and it will take us a decade to fix it. No, we can't. It can't take us a decade. We need to work at scale with cost-effective solutions, and we need to have a quick impact on the population. And the third element of that new roadmap is alliances, partnerships, understanding that we can't do those things alone. We have to coordinate our work with specific partnerships. As Pablo said, precisely the presidents of the two agencies, IADB and the World Bank, signed an explicit memorandum of understanding expressing their will to work jointly on digital issues, the Amazonia, and resilience in the Caribbean. So those were the three issues highlighted. But just for that specific alliance. And we are very interested in other very specific partnerships where we identify one challenge for development in Latin America and entering in the system. And it's crucial to work jointly in partnerships, in alliances that may enable us to move faster. So these three reasons. One, it's because primary health care is part of the core, is one of the core axes of the bank strategy. And second, because the pandemic fund shows us the relation between primary health care and being better prepared for a pandemic. And third, that for the bank's global mission of eliminating extreme poverty, and we need to work in alliances like this. Thank you. Dr. Barbosa, would you like to make a comment? Thank you. So let me say that the next question is on climate change, so we'll reflect on that. But now we wanted to focus on the role of IADB. Dr. Ibarra, we already heard from Dr. Barbosa the collaboration in the digital transformation. I'd like to know more about your work and how the digital transformation that you're working at the bank, how can you strengthen and support primary health care in the region? Yes, indeed. I think that the work that we have done in digital work and IT in the hand systems and hand in hand with PAHO for 5 or 6 years shows how important these collaboration schemes are. I think that there we start from some principles of work that are very good, respecting the technical work and collaboration, co-creation of instruments, and that allows us to work with countries fully aware that we are very well coordinated and that there's a route that we follow, a roadmap, the regional plan of action for information systems developed by the countries. We are working together to support the countries develop the tools they need, including the national strategy for digital health and a roadmap that may enable us to prioritize interventions and actions. So I think that this work has made it possible for us to act as members with the countries under a technical and operational understanding that's very important. As Dr. Barbosa said in the visit to the bank, where he was with President Coleman, an additional step forward was given in it's a Pan-American route for digital health. The idea is to achieve connectiveness and a transmission of data across the region, but the important thing is that this is an instrument to strengthen the healthcare systems for the entire region. We know that this is quite a recent phenomenon. In the last 8 to 10 years in Latin America, the migratory flows are huge, but most population don't leave their countries, but still they need interconnected healthcare systems that may enable sharing, for instance, accessing their medical records, having better screening methods. But I think that really we are at a stage where PAHO has the 8 pillars of digital health. We develop 6 key aspects that are very positively interrelated, and that enables us to reach the next stage, that is using digital health to improve services. It's like saying primary healthcare finds with digital health, and that gives a huge transformation power. The pandemic made it necessary to do that, and we moved forward much faster in digital development. We went backwards with immunization and other things, but digital health made progress, and we need to continue to move forward, because many of the measures that made us was leveraged needs to be consolidated so that those advantages may remain. So that would give us better services for more remote regions. We're working a lot in the Amazonian and in very scattered places where there may be inter, to consultations so that we can reduce gaps. We have a huge potential, and I think that the last 5 or 6 years show us that we can move forward, and we need to continue to work at that. Thank you for sharing experience as well. We said that we were going to talk about climate change today. As we speak, we have the COP on climate change in Dubai. They're debating on healthcare systems as a priority area. So my question is related to climate change and the healthcare areas. And this is for all. How can we work in the region? We know that we have problems with climate care. How can we develop more climate resilient healthcare systems? Thank you, Doctor. Health is the way people live and feel climate change. Health is the human face of climate change, but only after 27 meetings, yesterday, December the 3rd, for the first time, there was a day dedicated to health at the climate change COP, and I think that it is absolutely clear that these need to be joint agendas. Climate change presses very strongly on healthcare systems. On the one hand, it implies that there's an increased demand for healthcare systems, but at the same time, it harms the possibilities for the responsiveness of the system. And the climate crisis is highly impairing food security, access to clean air and water and sewage. So we need to consider the impact on people, on productivity and future growth of countries. So admitting that it's a joint agenda is in itself already encouraging. The bank is highly committed with the climate change agenda, mitigation and adaptation. As my colleagues will explain, it is crucial to move forward in this agenda. The World Bank, we measure the impact of climate change in the projects of all the sectors, from energy to renewable energy to the project of health and education. In all the projects, we measure the so-called co-benefits, climate co-benefits of each intervention. That may be very high in some sectors and lower in others, but we measure as all our portfolio has an impact on the combat against climate change. And some years ago, the objective that for 20 was to devote 35% of the funding of World Bank to climate change by 2025. That was already achieved, and we now want to have it to be 45% for 2025. So that shows the commitment of this agency.
So a new global program of climate change and health was launched. It will help countries measure their vulnerabilities, increase their investment in health systems that are resilient and with low carbon footprint, to mobilize resources to generate and socialize evidence on what is cost effective to face this crisis of weather and health, and to foster joint actions to advance in this agenda. And in that sense, this joint agenda between IDB, PAHO, and the World Bank is a key element in this global agenda. So it's truly consistent with what we are working on globally, and we believe that what we are designing, what we are trying to advance on regarding primary healthcare systems with the correct characteristics are crucial, not just to struggle against pandemics, but to adapt our health systems to the different needs that we shall have because of the climate change impact. Thank you. Thank you very much for this question. Jaime has covered many important issues. It is an urgent matter. It is estimated that we have 250,000 deaths worldwide that are related to the different impacts of climate change. People who are dying because of problems related to contamination, soil contamination, extreme weather events, disorders such as malaria and others that are related to weather change, to climate change, food insecurity in our region, drought in Central America, and all the problems regarding food insecurity and the problems of migrations because of the economic difficulties of many countries in the region. We have worked hard with countries in recent years, for instance, in the Caribbean, with the support of the European Union and the UK. We had an initiative called Smart Hospitals. That initiative has built or remodeled 50 health units, including health centers, and that only started with the issue of resiliency. Then we went into green. They had to be green, and they also had to be accessible. And that allowed some countries, when they had hurricanes, the whole government went to hospitals because that was the only building that was still functioning autonomously, was the hospital that had received this kind of intervention. Because in the Caribbean, for instance, some countries still have to rebuild health centers and hospitals every 3 or 4 years when there is a hurricane. So that is important. And when we think also on the role of primary health care, because it's closer to the community, because also for climate change, people who are most vulnerable are the ones who suffer most. So I also believe that this alliance is coordinated with this effort to make health systems be prepared to have a better answer to this threat from day one, from today, not in the future. We are talking about yesterday, probably. And we also, so we are very happy to have at least a day in COP, and the next COP will take place in the region, and in a particular region, the Amazonic region, which is greatly affected by climate change. I think we'll be able to call attention to the fact that health has to be included in that agenda so that it can have a better response. Thank you very much. Undoubtedly, on the 28th time is a good one. So finally, health was discussed. There is a context that is very positive to focus efforts. Also, G20, Brazil has just become president last Friday, and the issue of health and climate change is one of its priorities, and also for the G7. So there is a multiplicity here, and I believe that the alliance may contribute is a very concrete thing, specificity. There may be many declarations, but it's important to land. And it's clear that primary health care is how, because it seems that it is the silver bullet, but it is the way to work and face challenges of chronic disorders, mental health, and climate change, such as Jaime said. It's a dual shock because health systems or services demand increases and supply is affected. And the initiative mentioned by Dr. Barbosa, we were able to work in several countries on how to take these principles to primary health care establishments so that they may go on working during any disaster made by the or caused by climate change. I believe that our focus, the health sector, must be adapted to adaptation, responding to the needs that arise because of climate change, contributing to mitigation activities. 70% is transport and production. They're really the right. Telemedicine may help a bit when there is a transition of the energy grid also, or matrix. But it is important to have concrete suggestions on how to work. I would mention two. First, to fund this vulnerability analysis, investment plans, and to be clear that when actions are being implemented to strengthen primary health care, to do so with that idea of how shall we respond to new demands, because there are many health challenges, and some mentioned such as priorities and diseases that we want to do away with. We know that a bit more heat and vectors exploit, so there is a higher prevalence of dengue, fever, malaria, and other disorders. And we have initiatives to eliminate them, but then we have the counterpart because of climate change and also chronic diseases. 2 degrees higher temperature makes them worse, and so demand increases. And the second point is the regional component. There is a lot of public goods here, all that has to do to pandemic preparedness. We also participate in the pandemic fund, and it is interesting how PAHO, World Bank, UNICEF, and other organizations are working there. It is fundamental to focus our efforts. It is a subject that will go on occupying our attention, but I believe there is a possible way from primary health care to not lose focus. There are so many issues, and strengthening the network and primary health care focus would be fundamental. Thank you very much. They are telling me we have little time left. A final question for all of you. If you want to make a few final comments, as we always say in these collaborations, we have to assess in a few years' time. We have to see how to measure the success of this alliance. To reflect on your final words, and what do you think would be a success in 5 years' time? Well, that is a difficult question. Thinking on how to measure success, we can talk about data and information systems, but no, I will leave that subject for later. Success, I think, would be if in a few years' time we can see using as metric something that is more policy related. We may support technically and financially. Even our financial support is a drop in the ocean of what public systems spend in health. Of course, that funding is important because it can foster improvements, but funding at the end of the day in Latin American countries comes from governments, comes from people, from taxes. So success will be that we find that there is a political commitment in countries to develop the capacity to implement these programs to advance, because they require an excellent bureaucracy. That requires political commitment generating that capacity to implement, to generate those resources as an international financial commitment. It's not enough. We have good technical designs. That is important, and we may help. But if at the same time we do not have the capacity to implement with qualified bureaucracies that know how to interact with the private sector and also the funding, we will not be able to advance. And in order to have all those elements, you need political commitment. And that is what we would like to see more countries with a commitment to say that, yes, we want to advance concretely and quickly to provide all of citizens with the services they deserve. Thank you very much. I also believe that, briefly, first to have political commitment, strong political commitment of all the countries, as Jaime just said. In health systems in the regions, we know that there is a chronic problem of underfunding. There is an average of 4.5, 4.6 as public expenditure. There are few countries, including Uruguay, who are above the recommended 6%. We recommend at least 30% of the budget in health going to primary health care, because if primary care doesn't have that capacity to be really resolving 80% of the health problems, which with current technologies we know is possible, and at the same time that it is the organizer of demands for specialized services, because if the population does not see primary health care with a dual role, it prefers to go directly to an emergency service where it will receive care, which for chronic diseases is a problem, because it will have this circle, go to emergency every time there is an emergency. That accounts for premature preventable deaths we have. So I'm sure we will develop a series of indicators to measure the increase in coverage, in investment, in personnel training, all what makes programs be adapted to each country's realities and priorities, and with the result of an increase in real access of people to primary health care that is strengthened, capable to resolve, and that is an important step for resilient health care for universal health. Thank you very much. I believe several important things have been said already. I believe that beyond documented cases of collaboration, concrete collaboration, and having indicators of investment, reduction of hospitalization because of causes that could be taken care of at the primary health care, to decrease mortality because of chronic disorders. I believe that because of primary health care's approach to reach the community and to acknowledge the variety of factors, we will have to work and achieve an alliance reaching other sectors in the countries, for instance, ministries of economics, the education system, social determinants on one side. We have to work with the partners working in those sectors, and the ministries of finances and economics. We have to present the case for investment, which is obvious for us, but as Jaime said, we are in a group that does not need convincing, but we have to go to the ministries of economics and financing and present the information. We had a dialogue, and the Uruguayan minister was there. There were many people from the health and finances sectors, and sometimes they are speaking different languages and sitting around the same table, and there are people from the same country who are interacting for the first time. And it is important to have this in the alliance because it will give it sustainability. And if we add the investment of World Bank and IDB in health, and we double them, it's still a minimal part. We have to try to have incidence on the rest of public investment so that it is channeled to primary health care. The demand we always receive is for hospitals, and we need countries to invest also in the rest of the system.
Thank you, Doctor. I think that all of us may agree that it's been an inspiring session. We've learned a lot, and I think that it's very important in our world with so many crises. It's good to be give a message of hope. I think that the three speakers have agreed, and we wanted to thank them for their contributions. And now let me give the floor to Ernesto to go on with our agenda. Thank you, Helena. It's been really wonderful. I was looking at the agenda, and it said discussion panel. Actually, it was a dialogue, as Elena very well said, and very inspiring. So I need to highlight that almost all the key elements have been put on the table. Those are the topics that we're going to debate, these 3 days. First of all, they mentioned the challenges, both as a result of the pandemic, climate change, and all those challenges that have to do with the structural inequalities in the region and their impact on the healthcare systems and the inequalities in the healthcare systems. The second thing is how marvelous it is and how different players and different organizations approached primary health care, not just as a level of care, as a strategy, as how we can approach these challenges, and the various components that were mentioned were the elements that have to do with guaranteeing effectiveness, improving the role of the first level of care by articulating the entire network, the role of human resources there, digital health, and so on. And the nature of the alliance and the role of the various institutions, and also assuming that they are absolutely necessary. It's absolutely necessary for them to coordinate efforts and also to admit that without the country's initiatives, this isn't possible. And the final discussion, how do we imagine results? And the results in terms of political commitment of strengthening a much broader alliance, the dialogue between health and economy, and the need to have a monitoring framework where access may be key. For me, as Helena said, it was very inspiring. Thank you. In this new session, we will work until 11:30. The timing is very important. And to that end, we have organized a dialogue of authorities. It will be chaired by Dr. Kunamam Rosanatham, Executive Director of the Alliance for the Research of the Policies of Care by the WHO. Kumanam Rasananthan is Executive Director of Health Policy and Systems Research Alliance. He has worked for over 25 years in the WHO in the development of the SDGs and UNICEF and the health determinants of WHO included in the report of 2008. Welcome, Dr. Rosanathan. Thank you for participating at this event. Good morning. Good morning. It's an honor and a pleasure to be together in Uruguay to debate with all of you on primary health care. Minister Karina.
Representatives from the Inter-American Development Bank, from the World Bank, other excellencies, colleagues, ladies and gentlemen. I hope you will permit me if I continue in English. I think it will be easier on your ears. But it is very important that we are here again in Latin America. For me, throughout my career, this is the region where I have come to so many landmark meetings on primary health care, on our joint commitment to health equity. Because this is a region that has so much to share, to contribute, so much experience. What we have already heard this morning from this very interesting discussion stimulated by Professor Helena is this renewed commitment we have that primary health care, those beautiful principles articulated in 1978 in Alma-Ata in Kazakhstan, remain relevant to a very changed world. But at the same time, as we've heard, whether it's issues of climate change, the continuing challenge of conflict, the epidemiological transition where we still have new infectious diseases, but we have much greater burden of non-communicable diseases. The continuing challenge of equity, which requires action across the social determinants. This means that as we still stay committed to the principles of primary health care, we must change our approaches and think about what is needed in 2023 and going forward. And I think we heard some very wise guidance as to how that is possible. What we've also heard is that we need new partnerships. So how fortunate we are here today as we see this commitment from PAHO, the World Bank, and the Inter-American Development Bank for this new alliance to bring efforts together to support countries as they move forward on primary health care to achieve health equity and universal health coverage. In the wake of the painful experience of COVID-19, which has hit this region hard, we have seen the data on how life expectancy has reduced. Dr. Barbosa spoke about increases in maternal mortality. So sometimes it can seem very grim. It can seem, how can we move forward? So we had some advice on how that is possible from the leaders this morning, but I am delighted that I have the pleasure to moderate this panel, the second panel this morning, where we will hear from the efforts of countries, from ministers and vice ministers from countries who are taking this forward. So I will invite the colleagues to the stage, and again, how fortunate we are to hear how countries are moving forward on primary health care, but also their views on how this new alliance can best meet countries' needs. So first of all, it's my pleasure to invite Doctora Ministra Karina Rando, the Minister of Health from Uruguay, our host, to the stage, who we've already heard from this morning. I also have the pleasure to invite, and may I just confirm with my colleagues whether we have the Minister or the Vice Minister from Colombia? The Vice Minister, thank you, and apologies for that. So I also have the pleasure to call to the stage Vice Minister Luis Alberto Martinez, the Vice Minister of Social Protection and the Ministry of Health and Social Protection in Colombia. I also have the pleasure to call Vice Minister Eladio Perez from the República Dominicana, Vice Minister Edwin Montufar from the Ministry of Health, the Vice Minister from Guatemala, and last but certainly not least, Secretary Isabela Cardoso, who is from the National Secretary of Workforce Management and Education in the Ministry of Health of Brazil. Please. Great. And so just to confirm that, unfortunately, Vice Minister Edwin Montufar from Guatemala has not been able to join us. So if you don't mind, I will also move to sit with you. So, Minister Karina, Uruguay, we know, is a country with such a proud history on primary health care, including during the COVID-19 epidemic. And we at the Alliance have been fortunate to collaborate with Dr. Hernan and the office here and with your colleagues on documenting that experience. So perhaps you could tell us what are the priorities for you, and how is Uruguay taking forward and building on that history of primary health care to address the challenges of today?
Muchas gracias, Dr. Kuhneman. La verdad.
Thank you, Dr. Rasananthan. Yes, really, when we think of Uruguay, Yes, we do have a very important primary health care history where equality and solidarity play key roles in our system. And when you think of it, there's more than one example that could be of interest. But let me mention some, at least just to mention them because I think that they're important. And at the end, I will focus on primary health care based on Uruguay's funding system. It might be a bit of our motto. That is, we have achieved with great effort and a lot of dedication, we've been able to build upon an existing system every day. There are several areas where primary health care is outstanding in Uruguay. Let me share some of them with you, including, for instance, and this is something that was developed in recent years, prevention and promotion of health. Health prevention and promotion across the territory, including the most remote corners in the country. And why do you think this is important? Because it facilitates and it guarantees equality and access. The Ministry of Health is divided into a National Directorate of Health. The director is with us today, Adriana Alfonso, and a National Coordination Directorate, whose director is also here, Mariela Anchen. And there's a very important coordination between creating linkages between the healthcare system that has different program areas, sexual and reproductive health, mental health, palliative care, that promote and design the programs required for the promotion of health and prevention of disease. How can we make this universal? How can we allow all the population to have access to these programs? Well, that is done through the National Coordination Directorate. This is a directorate that has been strengthened a lot these recent years, and even more with the pandemic, because it is in charge of implementing the national policy defined by the Ministry of Health to the rest of the territory. We have a national health director that I see him here in the room, and the department directors of health in each of the departments or provinces in the country. They are in charge of implementing the prevention and promotion policy designed by the ministries.
That allows us to make health fairs, which are organized by local and departmental governments. We include interdiscipline. We include access to preventative measures such as cleaning throughout the whole territory in the country. So prevention and promotion is very important, and we have stressed it a lot after the pandemic, particularly strengthening that territorial area, which is the General Directorate of Coordination. That is one thing, but we have other sectors that are very important for primary health care in Uruguay. One of them is the implementation of telehealth or e-health or through telemedicine, but not telemedicine as telecare, but as reading of images and coordination amongst professionals who are in the most remote areas of the country and perhaps do not have access to specialist consultations and specialists who might be in metropolitan areas. This project of telemedicine and telehealth, which has been supported by PAHO, we think is important, very important for the development of primary health care because it favors access, egalitarian access throughout the whole territory. It favors equity because patients who did not have access to some specialists, for instance, to some diagnostics, have it through telehealth, because it also favors the quality and excellency. And I will say this as a wish, perhaps because we wish and we have a project to have mammograms throughout the whole country to be read with imaging systems that are of referral and counter-referral from some specialized center in the country, and even to do this with artificial intelligence so that specialists throughout the country may learn about reading of mammographies and thus improve screening of breast cancer throughout the whole territory. We think it is very important to include telemedicine and medicine that is associated to technology to reach the whole territory with equality, equity, and solidarity. And final, but not the least, but the most meaningful thing in our country is a funding system. Our health funding system started several or many years ago, starting with a health system that had a very wide coverage, but somehow not enough equity as it has achieved in time, a health system where the ministry used to cover the most vulnerable sectors of the population, not leaving anybody without coverage. We had a very wide coverage for many years, and collective medical care institutions, which are not for profit, covered middle class and upper classes. And this changed with the reform of the integrated national health system. And nowadays, I will not describe the whole history, but because it would be boring and we do not have time. But nowadays, we have a national system that is integrated with a coverage of almost 100% of the Uruguayan population. And the funding is very interesting. There is a fund, a National Health Fund, which receives contributions from workers and employers. And it is a fund that is interesting because of its solidarity characteristics. Contributions are proportional to your salary and your income of each contributor. So whoever earns more pays more, and through solidarity finances those who have less income and are more vulnerable. This system allows a funding and a sharing that pool of funding and risks amongst all health system providers in the country, and it also allows the out-of-pocket payment to be very little. Out-of-pocket payment in Uruguay is a very small percentage, and that is present in fees of different private institutions, private not-for-profit institutions. We wish to mention that this health reform that has occurred in recent years has allowed for a minimization of fragmentation. How does that National Health Fund get transferred to providers? We have public and private providers. Public providers are mainly the ASE system, the State Health Systems Administration, which covers approximately 1,600,000 users, of whom 600,000 people chose the coverage with the public services because, among other advantages, it has practically no co-payments. And there are 42 collective medical care services, which are private providers that are funded through this fund. Funding has two procedures. One is a per capita payment, which is adjusted by age and sex, and payment per goals or per performance. This payment is considered of relevance and important to point out because it allows the ministry as steward to stress the policies that we care about most: childhood, sexual and reproductive health, screening or for cancer, for instance. And those policies become goals with health of the programs that I mentioned before. They become goals, and providers who voluntarily comply with those goals, but they have an interest to comply with them because 6% of their income comes from them. So they comply with those goals and they reach excellency and quality in healthcare in those different aspects that the Ministry of Health proposes as important mechanisms. And finally, the other thing I wanted to stress about the system is its services. Services are defined by the Ministry of Health in a basic basket of services called PIAs, and they are the same for all providers in this country, for public and private providers. In that basket, we include drugs, care, surgery, any type of care that the Ministry of Health deems necessary and essential is covered throughout the whole territory. So we have an idea of equity that we are proud of in Uruguay. We also have a National Resources Fund beyond the National Health Fund, which also receives money and allows to provide high-cost services such as transplants, for instance, high-cost drugs to all citizens in the country. So we have a health system that is funded by a system of national fund that is equitable, that has solidarity included, that allows for universal services, and particularly the equality of services and a very low out-of-pocket payment for the whole system. I believe this is something we are proud of in our country. Thank you very much. Thank you, Minister. It's very
is building on its strong system with reforms in coordination, in digitalization and in financing. And I think one challenge we all have is to ensure that with digitalization, the greater use of mHealth or eHealth, telemedicine, improves equity and doesn't exacerbate inequities, because I think it can go either way. And that also your financial reforms to ensure that you regulate across the private sector and have some alignment with the public sector, I think it's very, very important and inspiring. So thank you, Ministra. Vice Minister Martinez, if we can now move to Colombia. A year ago, I had the privilege to be in Bogota, where Colombia hosted the 7th Global Symposium on Health Systems Research, which was a wonderful meeting. And there I had the chance to hear how the new government and President Petro, the commitment to equity and health systems reform. So it would be great to hear from you how Colombia is taking forward primary healthcare and this reform effort.
Okay.
good morning. Special greetings on behalf of my country and Dr. Gustavo Petro Rego, President of the Republic of Colombia, and the Minister of Health, Guillermo Alfonso Jaramillo. As Kumaran just said, our country is nowadays debating an important transformation of the general social security system in health. Precisely today, the lower chamber in the Congress should approve the transformation of the current system of general health social security. It will later go to the Senate. Unfortunately, our country in the past 30 years has changed its model of care towards a more curative approach, more of selling and buying services, with a system that is segmented according to the payment capacity. We have approximately 150 different providers, insurers, who become 150 segments and payers. And that has generated gaps that are very important between urban and rural areas. Market has concentrated high complexity services. The third level of care became somehow the entry point for the system, particularly emergency services that are always collapsed in the large cities. We also have fragmentation of care that provides the collective risk to subnational governments and individual care to insurers. And on top of that, we have a system that is based on competence amongst actors. With all that, we have a vulneration, a systematic vulneration of the effective enjoyment of the fundamental right to health. But nowadays, we have a very high investment, approximately 7.5% of our GDP. 30 years ago, before 100, low 100, we had only 2.5 points. So we tripled that investment. Nevertheless, we have an inefficient, inequitable system that has generated important gaps. So today our country is trying to advance materially to make true the dream of advancing in the effective enjoyment of the right to health so that every resident in the country may have access to more equitable services, and the reform thinks of a division of the country in territories to put services closer to needs, and primary health care is the main strategy underlying this reform, where we wish to strengthen this first level of care that we call primary care center, which have already have a design of how many multidisciplinary teams are needed, what is the profile of that team, of people who will be providing care to people, to individuals and families and communities, and how other providers are integrated in comprehensive integrated networks in the territory. So there we have all the technical, theoretical concepts and what PAHO has contributed to in Latin America and the Caribbean, the experiences of European reference countries. And together with IDB and the World Bank, we have also advanced in making true integrated health information system that does not only provide information on the care of people in the territory, but it also traces resources, because nowadays we do not know what resources have been spent on. There is a waste, permanent waste, and having given the market the organization of services, the allocation of resources, has led to the closure of services that are not profitable, such as mother and child services. 30% of our country now has no birthing rooms. We have 30% of the country that has no emergency services, and we also have an important number of municipalities that do not have basic hospitalization services for adults. And all that because specialized care has been concentrated in urban areas.
So today we have moved forward in defining the development plan, and a significant investment is spent to recover the supply of public healthcare services that has appeared as a consequence of this delivery of the healthcare system in the market, and this has been impaired in recent 30 years. But our development plan is already showing that we'll invest a lot to recover public facilities and to improve the synergism with the public and private universities to train the human resources that we need to cover the entire national territory. We are systematically moving forward, progressing gradually, and alliances like this will help us materialize our dream, having a healthcare system that may really help us have the populations enjoy the healthcare and controlling the social and economic determinants while protecting resources. So I'm very happy to be with you.
Thank you, Vice Minister. That seems a very ambitious reform and a challenging reform, but it's excellent to hear that Colombia has a high commitment towards government spending in the health sector. We know, sadly, in the wake of the pandemic, that many countries, the government fiscal space for health is reducing. So it's wonderful to hear that Colombia is able to ensure the resources there from the government sector, and that you're very much looking at the equity implications and trying to improve coverage in a more equitable way. So if we could move now to Secretary Cardoso, and Brazil also has a very proud history on primary health care, and of course the formation of the SUS in the 1980s, which was such a signal achievement. I had the pleasure to be in Rio de Janeiro in 2011, where we worked together with the government of Brazil on the World Conference on Social Determinants of Health with WHO. But of course, it has not been an easy few years in Brazil with the pandemic. So how is Brazil going forward now in primary health care in the modern era?
Buenos dias a todas e todos.
Good morning, everybody. As we have a translation, I'm going to speak Portuguese. I bring you the greetings of Anísia Trindade, our minister, and I want to greet the minister of Uruguay, Karina Rando. And let me tell you that the process that Brazil is experiencing starting in January 2023, when we recovered democracy and the defense of our rights, that has led us to resume structuring significant structuring policies that are essential to recover after the last administration. The pandemic has shown us the importance of having a public system and that provides universal healthcare services as the SUS, the Brazilian healthcare system. So this was a very important, we had very important teachings during the pandemic. In that regard, our minister has done a very significant articulation work, not just within the secretariats that are part of the Ministry of Health, but also interrelating with other ministries and other sectors, expanding dialogue and joint work, as many of the previous speakers mentioned, because there's a political choice. And today we see that in Brazil we had a political commitment for social inclusion, equity, and to consolidating our single healthcare system. And primary healthcare has been strengthened starting in January to today. We've had multiple investment made, and I'd like to mention it because we are speaking of important figures. We worked under the leadership of President Lula to promote primary health care. Today we have 52,000 teams for health and family. We invested a lot in strengthening the policy with the program More Doctors, More Physicians. That is a program that expands the multidisciplinary teams to act in the field of primary health care in Brazil. Today, we have 15,000 positions that were created in 2023, increasing by 2,500 the number of doctors that work in primary health care. So, and that expands the possibilities for training and specialization of healthcare professionals. So I was paying close attention to the previous speakers, and many of them mentioned human capital, investing in our social, in our healthcare workers and in primary healthcare. And I'm representing a secretariat that implements policies that bear in mind the healthcare professionals. And in that program, our idea is to appeal to more professionals and to encourage them to go on with their qualification, with their training. They are receiving specialization courses, but also with specific modules, for instance, like master's degrees and other movements and actions to understand the careers of those professionals, what those professionals bring, what training they can contribute with, but also we try to detect gaps, their needs, to make the primary healthcare system to work. Where do we want to where do we need to invest? What are the gaps that need to be solved? And also, we expanded the family healthcare teams with doctors, nurses, and social workers working in the territories. So today we have 280,000 community health agents. We are completing a technical training of 180,000 such workers. And in February we'll launch a new group that will give qualification to 140,000 such workers. Also in oral health, primary health care workers work integrated with other teams, also engaging in psychologists, pharmacists, social workers, speech and doctors, endocrinology, cardiology. That is a whole range of professionals that will be incorporated to that program so that we can reach the most vulnerable territories in Brazil. Brazil is a huge and very unequal and very diverse country, and all those actions are implemented with great effort in a process of reconstruction, of structuring our policies that are very important to us. There are many challenges, of course. If we think of the healthcare system we had 35 years ago as a public universal system, and the principles of equity and as we provide healthcare, that implies investing in training managers, trying to make the most of our efficiency and more engagement. As I said, there is an internal movement to articulate the Ministry of Health structuring policy, but we also hold a very intense dialogue with the rest of the federal government. The minister has worked a lot in that regard to ensure the enabling conditions across the ministries to approach a number of issues that won't be solved just by the Ministry of Health. And they are not under the governance of the Ministry of Health, but also significant policy for education articulation with the Ministry of Health to strengthen resilience, to expand residencies, and not just the medical, but also of other workers, and also to promote the discussing with the Ministry of Labor issues related to the increased value of our workers' protection policies, and whatever we can move forward on in a country that has such a range of management models. So we have been debating this for a long time. So we resumed our national board for the negotiation of the permanent healthcare system, and also engaging administrators, workers, union representatives, and the different stakeholders. In the agenda of that board, we also debate the careers in the healthcare system. We won't have time to mention them all, but there are other participations of Brazil in a number of boards and tables, such as this in this regional forum. And as we're here, I want to congratulate you for organizing this forum, because I think that this articulation enables us to strengthen this great collaboration network trying to further strengthen our health policies. In addition, it's a target or a goal for the Ministry of Health in Brazil to expand our coverage up to 90%. Today, that figure is 77%. We've done some things in that direction. I could mention them, such as strengthening dialogue and articulation with the managers and workers and civil society, in addition to other government agencies and everything we've done with international dialogue, thinking of technical cooperation processes that may strengthen us. I also want to tell you that we are investing in improving labor, and we want to strengthen the implementation of public health policies. More recently, we incorporated the Ministry of Health. A number of we incorporated digital health department because we've invested a lot in Brazil in that. And we know that if we want to attain our goals, there's a significant technology transition period where we need to strengthen the infrastructure of our units, but also we need the digital transformation that occurs because of the transformation of human resources and developing cryptic technologies. And we have invested a lot of that. There are things that need to cover all our education. And I cannot and I must highlight the new plan for accelerating growth with a great effort of the Brazilian federal government to enable Brazil to come back to resume its path of growth, including health growth. Our minister always mentions the fact that health policies are not just social but are development policies. That is how we need to conceive this new health pack, investing $30 billion, 30 billion actions to improve the healthcare system and consolidating the network so that we may be organized, efficient, and capable of solving the problems of the country and the population to address the inequalities we have. So we are responsible for that and we are committed to that. Recently, we created the gender equity, gender, race, and ethnicity equities program to improve our SUS to work. So this is what I wanted to tell you. These are the first things that I wanted to mention in this first question. But there's a lot more we can inform you, and we're going to do this in the future days. We're going to share it with the countries in this forum. Thank you for giving me this opportunity. Thank you.
Complex.
Ciertamente.
A lot of challenges to discuss, a lot of things that you are doing, but again, very heartening to hear that you're building on the success of the Programa de Saúde Familia, which we know is documenting its improvements in equity and coverage to further expand the coverage. Many common themes across, these are three very different countries, we know, but common themes around looking at your financial reform and ensuring you genuinely having coverage, thinking about the mix between public and private provision and how you steward that function, thinking how digitalization can improve equity and improve coverage, thinking about your workforce and the differing workforce needs that we have to address the demands of public health today, and also thinking about the intersection between clinical services and public health functions. I think finally something in common is this idea that we all have in this room that health is an investment, it is a political choice, it should be seen as the bedrock of social, economic, and environmental sustainable development, although that is sometimes a difficult argument to make with our ministries of finance. So this new alliance that is being launched here is exactly, as I understand it, the aim to support you to take forward these ambitious efforts. And you are the primary stakeholders of this alliance. The alliance is there to bring together the efforts of multilateral partners in the region to support governments, in the first place you, but also communities in an integrated way to move forward on primary healthcare. So the next question to all of you is your chance to give advice. We have senior leadership from the agencies here. You heard the discussion this morning of the aims of what the alliance is, of what success would be. What would you like to see from the alliance? What would be useful for you? Any advice you have so this alliance can really live up to its mandate and its purpose? And again, we have the pleasure of starting with you first, Ministra Karina Rando.
Muchas gracias.
Thank you very much. Now we have with the Christmas list for PAHO. No, don't be afraid. I had thought of really some things. Well, that PAHO, WHO, the World Bank, IDB are already working with us in developing strategies for primary health care in Uruguay. So this would be like reinforcing some of those strategies that we're working on and perhaps include a new one. But thinking it further, one of the most important things for us is to have a diagnosis of the at-risk populations, vulnerable populations, and their needs, because primary health care is based on providing the care that the patient needs, not just any care, not just any service, but the service that that population needs. And that is not always easy to determine. It's not always easy to know the percentage of hypertensive patients we have, the percentage of obese patients we have. So a situation analysis, a diagnostic of problems would be an important contribution. And to some degree, it has been done. But to insist on situation diagnosis so as to focus our energies on that. And more concretely, for instance, the goals that the country needs to tell providers to cover those needs. That could be a way in which these different agencies may help countries. Another thing is Uruguay probably is not the only country, but many others might have it. But we have a problem that health systems are defunded because there is an increase in technologies, new drugs, judicialization of medicine, people's request to include these new drugs particularly. And it sometimes is difficult for us as decision makers to decide which of those technologies will really be included and which won't. So cost utility, cost effectiveness analysis could be another important contribution of these organizations to carry out with us to help us decide which of all these new services should be included in our basic basket of services, such as the one we have in Uruguay for universal coverage. And finally, the study that has already been carried out in Uruguay initially, but that could go on, is the cooperation with the integrated national health system, the diagnosis of healthcare providers, the financial diagnosis about the human resources, and having a more clear, concise view on how these health services providers are in our country and other countries in order to be able to respond to the population health needs. Those are studies that are often difficult to carry out, that may be expensive, they are not simple, they need advisors. And I think this would be another way in which the World Bank, IDB, WHO, PAHO could contribute. Well, I have a few more, but we have little time, so I will stop here. Thank you. Thank you.
It was actually a very short Christmas list, I thought. Very generous. I'm sure they're happy to hear a longer one. I think really support on the analysis, looking at the epidemiology and the analytical needs, the considering around the financialization and the needs of the basket of services and the package, and also thinking around the analysis of the health service providers and how to coordinate between them and the alignment and stewardship. So it sounds like partly you want some health policy and systems research, which is close to my heart. So moving then to you, Vice Minister Martinez for Colombia. And you have a strong collaboration with, of course, PAHO, WHO, the IADB. My friend Jeremy Vayard is at the bank, and I'm sure he's here and does a great job. So what does he need to do better? How does he need to work with you better?
Okay.
Well, if Uruguay has a long list, just imagine us with the challenges we have right now with the transformation of the current system. Well, we say that initially there should be an alignment, a harmonization, conceptual harmonization, but among the three organizations in order to strategically be able to coordinate actions better. The previous panel members said how to harmonize these actions and to have synergies amongst the three organizations. Our country, as you know, will have to undergo a transition process that is important and based on WHO validated concepts on how to assess health systems in the world. We established four main components: stewardship and governance, where we have several spaces to recover the National Health Council. That is a important role of civil society with a permanent discussion with academia and private providers, and from the public sector stewardship. Lots of capacity has been lost there because the organization of services was handed out to the market. So we've got to recover those state capacities. Likewise, the creation of a National Commission of Social and Economic Determinants, and to repeat that in the territory. So there we also have work ahead of us, considering generation of resources, investment in infrastructure, in technology, but also in developing the human talent policy in health to recover technicians, auxiliaries, midwives in rural areas, to be able to set up a horizontal dialogue with communities that are Afro or indigenous communities in the intercultural model of care in the territories. We must also strengthen those capacities in human talent in health. And we also have an important challenge, which is to transform, address the resource administrators into that single fund that would become the single payer, a strategic payer that would allocate resources equitably according to the needs of the territories and not to give them to market, as is the case today. And all that strengthening a model of care that privileges civil society participation, that creates capacities, agency capacities, that we are subjects of rights in all the territories, that we advance in that strengthening of networks to go from competence to cooperation, the hospitals providing care, and all that going hand in hand with technology. So this alliance, we suggest that you accompany us in that, in supporting this new model of health system based on social insurance that is more distant from individual insurance, from commercial insurance that these 30 years have brought forth. So I think if you help us oriented that investment, particularly towards primary health care, not so much to high complexity, and of course including technology. So we have lots of work ahead of us, and we hope that with a synergy of actors in this alliance, Colombia may be able to show results in the short term that are important for the country and for all of Latin America and the Caribbean.
Slightly longer Christmas list than Ministra Karina, but very ambitious. You're doing a very ambitious reform. So across so many areas, in addition to some of the areas that Ministra Karina mentioned, also around social determinants, around social participation, around services and the participation of indigenous peoples and interculturalidad. So a very ambitious agenda for the partners to contribute to. And then to you, Secretary Cardosa, how can this alliance best support Brazil, its efforts? I think you know the jefe in the region is from your country, so I think you have a direct line, but what is the advice you could give?
We have to say that both with Pajo, that has been a partner of Brazil in the development of our actions. So I want to stress here that all the cooperation work that was articulated and very important with the Pan American Health Organization. I told Jarbas also the time that he has supported the Ministry of Health, also WHO. We are also working with the World Bank and IDB. What we have also is a list of needs. I believe this alliance, I would say the role of this alliance starts with this forum is the articulation, because that strengthens us and it places this policy in a dimension that is much greater, that goes beyond our countries, which is the international dimension. So having the opportunity of strengthening this forum with a set of analysis that could be a convergent problems in the countries, I think that strengthens us and also qualifies our processes of interpreting our own problems and needs. So I think that is something that we'd like to stress. It can be a great contribution of this alliance, analysis of needs, but also the dialogue amongst countries, what identifies converging questions and challenges that may help us in this struggle that goes beyond the health sector, as I mentioned. In the case of primary health care, talking about needs analysis, there is a challenge in transforming our large network of services into a good teaching and research network. Research, we identify needs of the single health system that may lead the transformations that are needed. So that is added to the work we have daily, that we know that we are at the head of services, everything is urgent, so we need to enlarge this cooperation in order to advance in a better analysis of needs, not just population needs, but also needs of people who are operating in our public policies and health policies.
Por exemplo, temos no Brasil, como eu mencionei, uma diversidade hoje de modelos de gestão dentro da relação público-privada. O que é que nós podemos fazer? Temos nos debruçado sobre isso, para além de uma política para os trabalhadores que estão inseridos no setor público. Qual é a política que podemos, considerando que o Estado também ele regula e tem que fortalecer as suas políticas de regulação, que mecanismos podemos pensar e estabelecer também olhando para os operadores da política e nessa relação o que é que podemos imprimir, né, enquanto condições para pensar também na valorização dessas trabalhadoras e desses trabalhadores. E outro elemento também que eu gostaria de destacar, para também não me repetir aos que me antecederam, é a discussão da incorporação tecnológica. E nós vamos precisar, como eu disse aqui, ter um período de transição tecnológica. E vamos precisar de muito investimento para entender cada necessidade num país com a extensão que tem o Brasil. Então, eu acho que temos aí alguns elementos que podem pautar e, claro, disparamos agora esse movimento essa aliança que com certeza se desdobrará em estudos mais profundos e apresentação de propostas, né, que faremos isso internamente nos nossos países, mas também partilhando com os demais a partir das nossas, do conjunto grande de necessidades que ainda temos. Eu destacaria isso.
Obrigado. And I think, similar to others, you said not just around needs analysis, but the important role of the agencies in facilitating this type of exchange between countries, which I think policymakers always enjoy. You're very different countries, but you also face some common challenges. And also, I think, again, this reflection on that we are in this time of tremendous technological transformation of digitalization. Perhaps we have reached a critical mass of the digital technology that really it can sort of help us to overcome some of these systems obstacles and pooling our knowledge, and all countries need guidance on that. So I think it was not such a long Christmas list, but I know that the colleagues will have taken close note of that and will continue to discuss with you. I think I'd just like to check with colleagues if we're done. Right. So to close, just to say, I mean, again, what a pleasure to hear from firstly our host, from Mr. Carina, but also from Vice Secretario Martinez and Secretary Cardoso, the experiences of three very different countries, Uruguay, Colombia, Brazil, long histories with primary health care, but you would have detected a slight difference in the narrative. I think in Uruguay, perhaps you have a sort of bipartisan, more consensus on the health system. You go one way or the other, but you are building, taking forward. I think you heard in the other two countries, in Brazil and Colombia, health is political, that you are embarking on what you see as quite a large reorientation of the health sector. And I think one of the challenges for many countries is that how do you embed that bipartisan consensus in a health system? So regardless of who is in power, how do we move forward on the health system towards these aims, towards universal health coverage, towards equity? Because managing these big reorientations is also challenging and has to be done with care. And I know you have very strong plans for that. I think secondly, we heard the challenges of the changing scenarios, that it isn't 1978, it isn't 1988, it isn't 1998, it isn't 2007 when I was in Buenos Aires across the river where 60 countries, where PAHO hosted a conference renewing primary health care with Dr. Carissa, with Dr. Hernan and many others here. So you are thinking how to meet those needs. Decarbonization, digitalization, profound transformations in our societies that the health sector needs to respond to. The continuing challenge of managing between all health systems are mixed, between the public and the private sector. But how do we align services and the packages so that we ensure equity and coverage regardless of which type of provider that you are accessing? We heard of the challenge of coordination between the different levels of the health system, between the different governance levels. We heard on, of course, again, the ensuring the services for non-communicable diseases, which become more and more important, but at the same time, the need for strong capacities around infectious diseases, including emerging infectious diseases. And then we talked about broader issues, social determinants, social participation, ensuring the needs and rights of indigenous peoples are realized. This is a big agenda, but luckily, we have this new alliance between PAHO, between the World Bank, between the Inter-American Development Bank, which is committed to building on all the excellent work they already do to support you, but to working even more closely together in an integrated way to help you realize your ambitions and rise to these challenges. So I'm always very optimistic and confident for this region. I would just like to thank you to the organizers for the invitation for me to have the privilege of speaking with all of you. And I'm sure we'll hear more in the rest of this conference about the experiences of countries in taking forward primary health care in the Americas and how this new alliance can even better help to accelerate progress towards the right to health, towards health equity, and towards universal health coverage. Muchas gracias.
Muito obrigado, and thank you very much.
Bueno, muchísimas gracias, colega.
Thanks a lot, colleagues, authorities. Thank you, Kumanam, for your comments. I think that it's a good, this is a good piece of evidence of the type of dialogue that we want to build these 3 days. The dialogue is not just literal, that is, questions and answers about this collective dynamic, not just for comparison of countries and the analysis in terms of each context, but also, as was previously said, based on the history, the track record of each country, the challenges each country faces, the way the countries solve their structural problems, their funding, and the delivery of services, even thinking very clearly of primary health care as a strategy, strengthening the responsiveness of healthcare systems. And in addition, we are trying to promote not only a prospective dialogue, thinking of the future actions, but also there was a very interesting dialogue about the members of the alliance. We heard a very interesting dialogue that was also linked to the previous. Now we are going to have a short break until noon, where we'll have the official launch of this alliance. Thank you for being here in this first part of the event.
Hola. Los invitamos a todos los presentes a ir tomando su lugar para dar comienzo al acto de apertura oficial.
We invite all of you to please take your seats so that we can have the official opening ceremony.
Sí, sí, sí. Muy buenas tardes a todos.
Good afternoon. We invite you to take your seats, please. With the presence of the President of the Republic of Uruguay, Dr. Luis Lacalle Pou, we shall officially open the Regional Forum Alliance for Primary Health Care in the Americas. We invite to the rostrum the Minister of Public Health of Uruguay, Dr. Karina Rando, the Director of the Pan American Health Organization, Dr. Jarbas Barbosa, the Director of Human Development for Latin America and the Caribbean of the World Bank, Dr. Jaime Saavedra, and the representative of the Inter-American Development Bank.
Para dar inicio a esta sesión.
To start this opening session, we invite the Minister of Public Health of Uruguay, Dr. Karina Rando. Good morning to you all. It's a pleasure to be here with all these guests. Mr. President of the Republic, Dr. Luis Lacalle Pou, thank you very much for being here with us. It's a great joy. Mr. Director of the PAHO, Dr. Jarbas Barbosa da Silva, national authorities, representatives of international agencies, ministers and vice chairs, visitors from friend countries, representatives of public health ministries of friend countries, former ministers of health, deans of public and private schools in our countries, representatives of specialized agencies, directors of departments at the Ministry of Health, members of the health system in the public and private sector. You are all welcome in Montevideo, Uruguay. It is an honor for the Ministry of Health to have worked closely with the PAHO office in Uruguay with the collaboration and support of the Presidency of the Republic, the Ministry of Foreign Affairs, the Ministry of Interior, the Ministry of Tourism, and the Administration of State Health Services to carry out this regional forum on primary health care. To all of them, thank you very much. The idea of primary health care has been repeated and redefined on multiple occasions since its onset in Alma-Ata in 1978. In 2003, the Directive Council of PAHO mandated member states to strengthen primary health care with the creation of a document renewing primary health care in the Americas, a position paper of the Pan-American Health Organization and WHO. This mandate reached its most important thing with the Montevideo Declaration, which was disseminated through the Pan-American Health Organization's journal in 2007. Member countries made a commitment to renew and enlarge primary health care as the cornerstone of a sustainable health system that would allow the achievement of universal health, the Sustainable Development Goals, and health security. This commitment has been repeated in Resolution 72.2 of the World Health Assembly, the report on the follow-up of universal health coverage 2019, and the high-level meeting of the United Nations General Assembly on universal health coverage. Today, based on the definition of the World Health Organization and UNICEF, we understand that primary health care is an approach of health that includes a whole of society, whose objective is to guarantee the highest possible level of health and well-being and its equitable distribution through people need-centered care as soon as possible throughout the continuous process that goes from health promotion and prevention of disease to treatment, rehabilitation, and palliative care, and as close as possible to the daily environment of people. Primary health care is of great importance at the time of defining health policies because it is the most inclusive, equitable, cost-effective and effective approach to improve physical and mental health of people, as well as their social well-being. Investments in primary health care have shown to improve equity and access vis-à-vis health services, the performance of health services, accountability of health systems, and health resorts. Besides factors related to the health system and access to services, there are other factors such as social protection, food systems, education, and environmental factors which are fundamental in the configuration of health and well-being. Primary health care is also fundamental for health systems to be more resilient in situations of crisis, more dynamic in the detection of the early signs of epidemics, and more ready to act early as a response to an increase in demand for services. It is also possible that this strong orientation to primary health care that characterizes our health system in Uruguay, together with the leadership of health authorities and the trust of population in the government, has had an influence in the important performance achieved during the epidemic of COVID-19. I share some key data taken from the Pan American Health Organization webpage. At least 3,600 million people in the world, that is half of the world population, still do not enjoy a complete essential health care coverage. Increasing interventions in primary health care in low-income and medium-income countries could save 60 million lives and increase life expectancy in 3.7 years by 2030. In order to achieve the primary health care goals, we require an additional investment of $200 to $370 million per year, with which to provide a package of services that is more complete. A health system that is based on primary health care orients its works towards equity and social solidarity. That means that every human being has the right to enjoy the maximum degree of health that is attainable without distinction of race, religion, political ideology, or socioeconomic condition. The principles required to maintain a system oriented towards primary health care are capacity to respond in an equitable and efficient manner to the health needs of citizens, responsibility and an obligation of governments to be accountable, sustainability, participation, orientation towards quality and safety, and the implementation of interdisciplinary interventions. In America, there are still many things to be done. That is why in this forum we try to achieve different objectives. We want to launch the Alliance for Primary Health Care to support countries in their expansion of primary health care at the regional, local, and national level. We also wish to exchange experiences and good practices because innovation, implementation, and funding of primary health care that we are considering. Also to share initiatives and tools by WHO, PAHO, World Bank, and IDB that were developed to support the implementation of primary health care and to set up a multidisciplinary network of cooperation amongst our countries. Uruguay welcomes you and makes a commitment to work jointly with all member countries to achieve universal health coverage through primary health care in the Americas. Thank you very much. We thank the words of the Minister of Public Health of Uruguay, Dr. Karina Rando. With apologies for not participating in this meeting, we have receiving a message from the Vice Chair of the World Bank, Dr. Felipe Garamicho, that we share with you now. Good morning to all of you coming to this forum. Today we are celebrating the launch of the Alliance for Primary Health Care in the Americas, which together with the Pan American Health Organization and the Inter-American Development Bank, we present to all of you with an objective, which is to promote healthy environments, prevent disease, and save lives. In the World Bank, our focus of action and impact is people, their well-being and prosperity, and benefit of societies with more opportunities for development and inclusive development and growth. And it's not by chance that we are launching this alliance from Uruguay. We applaud the decision and political decision-making of the country to strengthen its health system through primary health care. And as President Lacalle has rightly said, in other opportunities, the role of the state is to reach everybody in the whole territory. I am proud that the World Bank has been supporting the strengthening of primary health care for over 15 years in order to face challenges such as non-communicable diseases and more recently the mental health crisis. That is the sense of our alliance to support the expansion of primary health care in all countries in the Americas through more investment, innovation, and implementation, providing our knowledge, scaling up best practices, and providing orientations for the formulation of public policies that are effective, thinking of the well-being of people. The COVID-19 pandemic left lots of teaching. We know that the most affected people were the most vulnerable groups, and that showed the weaknesses of our health systems. We also realized that there were pre-existing weaknesses. On average, the OECD countries invest almost $4,000 per person per year in health, while in Latin America and the Caribbean, investment does not reach $1,200. So we have a long way to go, and we have no time to waste, and that is the value of primary health care, where we must strengthen the efforts and investments.
Fully aware of the situation, we have joined this call, and the World Bank is contributing with financial instruments to Argentina, Brazil, Honduras, and Dominican Republic, among others. We share the goals of the Pan American Health Organization and the World Health Organization working in the approach of future pandemics and the importance of raising the quality of healthcare services. I wanted to highlight this alliance to improve the resilience of health services in Latin America and the Caribbean, to better support the countries in these objectives and in these goals, and to contribute to this global challenge. We have the feeling of urgency to strengthen primary health care in the Americas by expanding access, quality, equity, efficiency, and resilience of the healthcare system. It is essential to have the political commitment and the implementation of state policies, and this alliance will make it sustainable for the impact and the benefit of people, our main common goal. Thank you. We also share the message by the president of IADB, Ian Goldstein.
President Lacalle Pou, distinguished ministers, colleagues of the Pan American Health Organization and the World Bank, and also partners. I wish that I could be with you all in person for this important event. The IDB is pleased to join our partners at PAHO and the World Bank to support countries in building strong and resilient primary healthcare systems. This is an essential partnership for the region. Primary healthcare is strategic and transformative for the economies and the people in our region. Boosting healthcare is crucial to improving the health and well-being of our citizens in Latin America and the Caribbean, and laying the foundation for more prosperous societies. The region needs investments and innovation in primary health care to address the growing burden of non-communicable diseases in the region, from hypertension and diabetes to mental health. We need new and better ways to deliver care and engage patients to effectively control their conditions. To be effective and equitable, primary healthcare must be intersectoral. That means that we must look both within and outside the healthcare sector and coordinate efforts across sectors and stakeholders. The Alliance for Primary Healthcare in the Americas is a crucial step in this direction, as it provides a collaborative platform to support our countries. I am confident that partnership and alliances like this will allow us to accelerate progress toward better health services for the people of our region. I wish you the best of success during the sessions this week, and I look forward to working with you for stronger healthcare for Latin America and the Caribbean. Thank you.
A continuación.
Now we invite Dr. Jarbas Barbosa, Director of the Pan American Health Organization, who will share the message for this official launching of the Alliance for Primary Health Care in the Americas and its regional forum. Thank you. Good morning, Mr. President of the Republic of Uruguay, Dr. Luis Lacalle Pou, Dr. Karina Rando, Minister of Health, ladies and gentlemen, ministers, deputy ministers of health, Dr. Jaime Saavedra, Director of Human Development for Latin America and the Caribbean of the World Bank, Mr. Pablo Ibarra, head of the Social Protection and Health of the IADB, former Minister Daniel Salinas, who's with us too. Ladies and gentlemen, let me start by thanking the government of Uruguay and especially President Lacalle Pou for receiving us today at the Executive Tower for this regional forum, a national forum for the primary health care in the Americas. In recent decades, Uruguay has implemented public health policy that have raised the performance of its health care system. The national integrated system provides 100% coverage of the population with 6.3% of the GDP, one of the highest in the region. Celebrating this regional forum for the Alliance for Primary Healthcare in Uruguay is especially symbolic, since in 2005 Uruguay started a new regional plan. His Excellency President Lacalle Pou allow me to pay tribute to Dr. Carissa Etienne, who died last Friday. Dr. Etienne worked tirelessly for primary health care. First, as in Dominica, in her country, we lost a wonderful champion for primary health care. Strengthening primary health care is essential for more resilient systems, inclusive, better prepared. And we couldn't have a better time to decide on collective measures. We have just suffered one of the most devastating events for public health in the last century. COVID-19 had devastating effects, not only in health, but also socially and economically, and was the cause for many deaths in the Americas. Unfortunately, our healthcare systems were not prepared for a pandemic. In the Americas, we lost almost 3 million lives. Almost 4.7 people were expelled from middle class and joined the poverty sectors in the region. COVID won't be our last pandemic, nor will it be our last public health challenge. Climate change is having direct impact on the health of our populations and the planet as a whole. Primary health care is essential for the resilience of our societies and healthcare systems. It is the vital element of effective and resilient healthcare systems, which is the key to strengthen the collective health of our region so that we can be better prepared for future crises. It is also our path to recover the progress made that we lost, changing the and going back to getting our maternity death rates and to improve non-communicable diseases such as HIV, tuberculosis, malaria, tropical diseases, neglected diseases, and expanding access for the prevention of chronic non-communicable diseases and mental health. Primary health care is a strategic focus that approaches the needs of people wherever they live. It is focused on the people, and it's based on responding to the needs of all, whether they live in the downtown areas of cities or in the most remote geographical areas in the country, to ensure equitable health and fair health services and to be more inclusive. It is absolutely mandatory to invest, to innovate and implement primary health care in the Americas. Please allow me to change to English to address Canada, United States, and the Caribbean countries.
Invest more and invest better in health. Healthier people live longer, more productive lives, contributing back to the development of their communities and countries. Increasing public expenditure in health to at least 6% of GDP, progressively eliminating out-of-pocket expenditure in health, is necessary to ensure universal access to health and universal health coverage in the Americas. In particular, decision makers must invest in developing our human resources for health in order to make up the massive shortfall of 600,000 health workers we need by 2030. Countries can achieve efficiency and better health outcomes by investing in interprofessional teams and collaborative care, ensuring the protection and well-being of their health workers. Beyond the workforce itself, countries must invest in institutions. This means fully financing health budget lines and investing in national public health institutions and laboratories that will strengthen health infrastructure and public health capacities. And this also means ensuring that funding is appropriately allocated and targeted to reach the most vulnerable and address inequities in health outcomes. Second, we must embrace innovation to accelerate and scale primary health care. We have an important opportunity to leverage modern technologies and advancements in digital health to this end. Countries are deploying telehealth services and digital portals and solutions to better reach underserved areas, increasing and expanding access to services, and ensuring continuity in care, linking people with the health workforce. Innovation is required in rethinking models of care and restructuring our health services to account for new epidemiologic, socioeconomic, and demographic realities. Innovative health financing mechanisms, such as risk-adjusted capitation payments to providers, can strengthen the localized approach to primary health care, while taxation of health products and purchasing agreements between the public and private sectors are other avenues we must continue to explore to improve health and well-being. Finally, we must go beyond political declaration and aspirational statements and translate theory into practice. Health systems based on the strong foundation of primary health care must become a reality. Strengthening stewardship and governance capacities at the national, subnational, and local levels, involving the active engagement of the community, can ensure sustainability in action. Because stronger health systems rooted in primary health care benefit everyone. They improve health and well-being, spur economic growth, and make our world a safer place. This is why PAHO is working intensively with our member states and partners to build sustainable strategies to improve primary health care, informed by lessons learned from the pandemic and more than a century of experience improving public health throughout the Americas. Building a new alliance for primary health care in our region is needed now more than ever to accelerate action at the country level through collective and concerted actions. Through our partnership with countries, with the Inter-American Development Bank and the World Bank, we aim to work together to guide and shape investments in health, leverage innovation, and accelerate the transformation of health systems based on the primary health care approach. My thanks to our friends in the IDB and the World Bank for joining forces with us in this endeavor, and we look forward to building this partnership to benefit all countries in Latin America and the Caribbean. Together, we can build resilient health systems that protect the people and ensure their right to health. By investing, innovating, and implementing primary health care, I am confident we can create a healthier and safer future for all in the Americas. Thank you.
Muchas gracias, Dr. Barbosa.
Thank you very much, Dr. Barbosa. We invite you all to watch the video of presentation of the Alliance for Primary Health Care in the Americas.
La pandemia de COVID.
The COVID-19 pandemic was. There will be no translation because there is subtitles.
Y un después en la salud pública global. Los sistemas de salud no estaban preparados para responder a una emergencia sanitaria de esta magnitud. No será la última, y debemos estar preparados. La atención primaria de salud es la estrategia para responder a las necesidades en salud en las Américas. Y es vital para recuperar los logros perdidos. Estamos ante un punto de inflexión. Es necesario transformar los sistemas de salud de las Américas para que sean más resilientes, equitativos y eficientes. La Organización Panamericana de la Salud, el Banco Interamericano de Desarrollo y el Banco Mundial comparten esta visión y unen esfuerzos para conformar la Alianza para la Atención Primaria de Salud en las Américas. Una alianza que promoverá la expansión de los sistemas de salud basados en la atención primaria de salud para garantizar una atención integral, de calidad y accesible para todas las personas, ya sea que vivan en las ciudades o en las zonas más remotas. Las tres organizaciones unen esfuerzos para trabajar con los países de América Latina y el Caribe en el desarrollo de planes nacionales de inversión que apoyen la expansión de sistemas de salud resilientes. A través de acciones coordinadas, la alianza busca impulsar la innovación, acelerar acciones para mejorar la disponibilidad y calidad del personal de salud y promover una mayor coordinación en el financiamiento de la salud para fortalecer la atención primaria de salud. Sistemas de salud resilientes benefician a las personas, comunidades y países, mejorando la salud y el bienestar de toda la región. Estimulan el crecimiento económico y contribuyen a un mundo más equitativo, seguro y próspero. Es momento de actuar. Invertir, innovar e implementar el enfoque estratégico de la atención primaria en salud. Es el camino para ampliar la cobertura de salud y garantizar el acceso universal a la salud para todas las personas, en todas partes.
Before closing, we remind you that you are all kindly invited to the welcoming cocktail that will take place today at 7:30 p.m. at Santos Palace. Those of you who are at the Radisson Hotel will be taken there. We thank the presence of the President of the Republic and the national authorities and all of you. Thank you very much and have a very good day.
Vamos a proceder a sacar la foto.
We shall now take the official picture. We invite the President. Thank you.
Hola, hola. Los convocamos a todos para el almuerzo en el hall.
You are all invited for lunch at the lobby. Enjoy.
facilities that try to take it to all. So, and we all have a, we all need pollinized cross-pollination. For instance, in El Salvador, where they mentioned that pregnant women that live in hilly places that they won't have the time to reach childbirth rooms. There are places where women can live the last week of their pregnancy. And for instance, I visited a place that had 8 to 10 places for women. They receive care, they receive classes, they get trained on how to rear their children. So they have the facilities available so that they can go there, because maybe they'll have a storm the day of, and they end up having their children at home. So it's taking the best ideas from one country to the other, from one healthcare system to the other. We think that that is a key task of these agencies. Not only do we provide funds, but also knowledge. We're constantly traveling from one country to the other, looking at these projects throughout Latin America, so we can take that knowledge acquired from one community to the other. Maybe a community thought of something that others haven't thought of yet, and that's essential. And the last thing I wanted to mention is that it's all hard for us to go to the doctor. I'm sorry, my apologies to the doctors here, but and so once you feel the first symptoms, you reassure yourself, saying that that will soon be over. But we need to provide basic knowledge to all so that we can help the people by our side as in their specific needs. For instance, and another case of Ecuador, for the issue of providing care to pregnant women so that they can have all the pregnancy visits, how difficult it is for them to attend. I've visited many healthcare centers in Ecuador, and by now there should have been somebody receiving care. And if I could talk to the doctors there, it's because the people hadn't, the users, the clients hadn't gone. So, and they organizing a 40-hour course that has already been taken by 40,000 people in Ecuador. So for CAF, that is more than anything that we have done in our history. 55 community healthcare workers that get trained to help their neighbors, promoting the antenatal care, because that will determine the quality of the childbirth care, nutrition, and the growth of that child in the future. Thank you, Pablo. That highlights the importance of people-oriented care that is also adapted to geographic and cultural context of in the country and to the area where the population lives. And in addition, and how important new technologies are and how they have to be taken to the population. So here we have 3 international funding agencies, the IFIs. But in USAID, it's bilateral. We have a long history of cooperation with USAID with many countries in Latin America. From the bilateral standpoint, how are you seeing APS, that is primary health care? How do you see the cooperation by USAID? Thank you. I'm sorry, I don't speak Spanish. I haven't. But primary health care for us is essential. That's the staple of our investment. And it's very important if we want to achieve the other goals of USAID, that is, to combat infectious diseases, to fight against HIV/AIDS, and mother and child health, to improve access to sexual and reproductive health, and now to have a One Health approach, so that people can, so that we can fight against pandemics. And now we have an initiative that's called Primary Impact that is well advanced in 7 countries in America, Asia, and Africa: Cote d'Ivoire, Ghana, Kenya, Nigeria, Malawi, Indonesia, and Philippines. And Primary Impact deals with the coordination of investment for health, of USAID, from malaria, mother and child health, reproductive health, HIV, to improve primary health care access as the basis of programs, and to improve the coordination among all those health areas, to expand that in a comprehensive way, and to strengthen the healthcare system through all those vertical programs. And recently, recognizing the importance of human health, human resources, we have the initiative War on a House Global Health Initiative, and that shows how important, the importance that we saw in strengthening healthcare. That's the foundation of primary healthcare. And we also have Community Health Delivery Partnership. This partnership will expand access to primary health care, and it will improve and enhance support for community healthcare workers, which is essential if we want to improve access to primary health care in countries. So, and now, as we also recognize the importance of partnerships. Recently, we signed an agreement with GFF, the Global Finance, with GEF, the Global Financing Facility, because it's an important platform to improve access to primary health care, using that as a foundation to strengthen the system so that people can make the most of the various partnerships available to strengthen the primary health care systems. That shows our commitment of using those partnerships at a country level and globally. Excellent Spanish. Wonderful, Rina. Congratulations. Well, thank you, Rina. And now, Deputy Minister Mestras, good afternoon. Here we have the Minister of Health of Uruguay, too. She gave us a class on primary health care this morning. It was such a pleasure to listen to her, and describing the approach of Uruguay. We know that Peru is also trying hard to expand their healthcare system based on primary healthcare. And with the international partners, we acknowledge that the main funding is the public funding. So, Deputy Minister, Peru has had great successes this year. However, you face a significant challenge in terms of public funding. How do you think you could approach that challenge in a sustainable manner in future years? And what role do you think that international agencies can play in that regard? Yes, it is true. I think that all countries face great challenges, but Peru in particular has had a great achievement before the pandemic, precisely before, that is universal health coverage and ensuring that coverage. I think that that has been the greatest step forward in Peruvian health in the last 100 years. So at present, we have ensured coverage to 99.99%, and that very small the 0.01% that is not that doesn't have it. It's because of administrative issues, either because they are newborns or people in transit in the country. So, and this is a pre-pandemic achievement. Then, during the pandemic, we had something that a very terrible blow, and that is the lack of response or the poor response of the primary health care level, because it was closed. And there's a debate in Peru. It says, was it closed because the system was too precarious or because the doors were physically closed? So the challenges we face include ensuring the coverage that is assured and to really providing the health care. And that depends on the first level of care. The key to success is to direct funding to the territories. So the cross-sectionally, and from the local sector to scale up to the most complex. It's the other way around. It's reverting the scheme that we used in the past, and that's a challenge, because whenever you say in Peru that we are going to strengthen the first level, people ask, what's the formula? I think that the key way is to provide the funds locally with some characteristics. First of all, the citizens' engagement. So citizens themselves have to acknowledge this challenge of and use and to apply co-responsibility and self-care of the population. And likewise, the local authorities, the municipalities, the districts, the authorities in a country that has such a range of diversity. Each strategy is important for each territory. This also happens, this also depends on a key important strategy that includes the data systems. They need to change the paradigm locally toward patient care focused, centered systems, and focusing on the client's needs with regard, and not the healthcare providers, including technologies, medication, human resources. And to that end, it is necessary and it is essential to create local competencies, including the use of technologies in districts in Peru at a local territorial level. And we always need to use open source software based on international interoperability standards. Since we have a country as Ecuador, Peru is much more diverse. People live extremely different realities from a point of view of climate, weather. So we can go from one region to speak in different languages, and going from the coast to the sea, and to the different to a forest. But so infrastructure needs to be addressed locally, and it needs to be an infrastructure that is very environmentally friendly, an environmentally sound infrastructure, including solar panels and electricity and water supply for biomedical devices, and satellite communication where we don't have access to cable and fiber optics. I think that this is just a brief overview of how partners could collaborate and what could be the partners' roles, especially if we want the local system to be resilient and to respond.
And to be sustainable, since in Peruvian populations in the Andes and in the jungle, we may say that it's not just green but also blue, because in the Peruvian Andes, we have the greatest water reservoirs in the world, and that is a responsibility not just with the country, but global responsibility. These waters go towards the jungle, which is the largest jungle in the world, which is the lung of the world. To look after the health of the guardians of these two resources is responsibility not just of the country, but of international agencies, of health partners, financing organizations, and it is an investment that will have returns, not just for the country, but for the whole planet. I think those are our approaches, and that should be a regional look and a global outlook. Thank you very much. Thank you, Vice Chairman. So the question to the panel members is whether we are doing enough to increase investment in primary health care. In the morning, we heard Dr. Barbosa say that it should be at least 30% of public expenditure in health going to primary health care. And there is a main source of funding, which is the public sector. We are also going into private funding in Latin America. I wanted to ask Tanya and Pablos, what is your opinion about it? Primary health care investment, what do we need to do? Thank you. The World Bank works with a centralized model, starting from the development priorities defined by governments through their national investment plans, which are channeling health investment. So the World Bank, from our side, we do not support initiatives that we considered our priorities, but that have not been defined as such by governments. So we work a lot with governments so that they prioritize primary health care, and I think we have managed to achieve it, because when I see the mobilization of resources and the portfolio of projects at the bank, we mobilized approximately $35 billion in the region, which are divided between more or less 15 sectors. But regarding health, only health, there are $4,000 million. So that is more than we consider if we only consider a division amongst sectors. And amongst the investments in health, over half of them include actions in primary health care. So I would not say that it is the only priority of governments, but I see that it is amongst their priorities. And also at the bank, we prioritize policies and investments, sectoral and multi-sectoral ones, for which the bank may contribute added value through not only through its financing instruments, but also via the generation of knowledge, technical assistance, and our advocacy and influence. So we share a lot the lessons learned in primary health care worldwide with the countries in Latin America, and investments that we are supporting to strengthen primary health care in health in Latin America include 4 or 5 large areas. One of them is the area of funding. For instance, in Chile, we are supporting the universalization of primary health care in order to cover new population groups and to improve the payment mechanisms of primary care. In Argentina, for instance, we are supporting capitation based on performance functions. For instance, the achievement of tracers, such as diagnosis and treatment of breast cancer. So the idea is to improve the efficiency of expenditure and to align expenditure with the government priorities, such as the minister spoke about a similar experience in Uruguay. Another area of importance for the bank is digital health, and we have several projects that are supporting primary health care through, for instance, single records and improving the continuity and coordination of care via the strengthening of electronic health records and integrated health records. We have a project in the Buenos Aires province, a project that will be approved in 2 days' time in the Dominican Republic about digital health. Another area for us is through primary care to strengthen the approach of non-communicable diseases. In Costa Rica, we have developed a model of integrated networks, including primary health care integrated to the secondary and tertiary care to improve early diagnosis and prevention and timely management of non-communicable diseases, making a more efficient use of resources. And other area that we have already discussed is to support resiliency and how, and just as you have said, at the Caribbean, we have several investments in smarting of health infrastructure, not just at the hospital level, but also on primary health care, in the primary health care infrastructure. And in Colombia, we also have a project that supports implementation of new standards of infrastructure to be adapted to climate change consequences. So I mention all this just to say that the bank has 5 strategic directions, and that to strengthen resiliency of public health systems through primary public health care with PAHO, and to achieve effective universal coverage through primary health care and quality care, to ensure that health systems are ready for future public health emergencies, to mobilize a level of funding that is adequate, and to guarantee that resources are properly used, and also to invest in interventions that are of high risk and based on life cycle, and to reduce the number of diseases and to achieve a healthy aging of people in the population in the region. I believe the bank really supports governments in their priorities, and when we can, we exert an influence of those priorities, bringing lessons learned globally. Thank you very much, Tania. Series of activities that is very large. And now going to Pablo. Pablo, would you make a recommendation, or according to the recommendations of the countries where you work, how do we improve primary health care with more strategic investments? How would you do it? Yes, I believe the starting point related to the question you asked is if we do not invest enough in primary health care, the pandemic results show that it wasn't enough. And also the countries that invest most, like Uruguay, were the ones that had better management of the pandemic. So we have to acknowledge that not enough has been invested, never mind if it is funded from the Treasury or international agencies. That has not been enough. But how do you incentivize countries? Because we respond to what countries propose. We go hand in hand. One example in Colombia, for instance, where we worked with the World Bank, and we have joint missions, joint meetings, And I was telling the vice chair this morning, when there is clarity from the government, the best coordinator that might exist is government, because they own the banks. So we can bring experiences, studies, and sometimes they are needed. For instance, one of the studies that we suggest in the Alliance, let's have investment plans with good costing. Also, the case for investment, to be able to show how convenient it is to the finance minister. And if a country says, I want to invest a certain amount in hospitals, to be able to show what would be the health gain if that was invested in primary health care. But Dr. Barbosa said, you've got to invest in hospitals as well, because I have never visited a hospital where you said, oh, no investment is needed here. But there is a balance, and I believe that more than telling countries how to do it more strategically, we have to help generate that. The colleague from Brazil said it. One of the contributions we can make from international agencies is to provide input and room for space, which in the 5 minutes they have every month to think of things that are not a daily practice, to be able to think on how to improve institutions and projects. We carried out in Honduras this year with an important investment in hospitals. We insisted and worked with government, and the government didn't just accept it, but was convinced on the importance of invested in trauma hospitals, but also in all the emergency and transport services and the human resources, which is something that you always mention, James, to manage that infrastructure. I believe this wide approach to primary health care networks makes us be ready to provide those answers. It's not that we had the alternative to reach government and tell them, well, this would be the health gain if an investment was made half in hospitals, half in primary health care. We did not have those studies ready, and that would be an important contribution we could make. Yes, true. Thank you very much, Pablo. What the minister said in the morning was the strategic approach of primary health care, which includes all levels of care, from the first level of care to hospital care, and the integrated health networks. Thank you, Pablo, for this. And Pablo, CAF makes pre-investment plans. How do you approach the work of the analytic social part with the countries? And what can we learn? Previously, you asked how do we make investments more efficient. And the first thing I thought is, what people ask is to make my time more efficient, the time I devote to accompanying a child whose ear aches, and if I have to go to a general hospital, I might have to wait for 10 hours, sometimes even standing, because there's no room, and I'm standing for 4 hours because of earache. And what people ask for is, make my time use efficient, that I have a health center nearby. And sometimes you think, well, isn't there a shortcut? Isn't there a way without investing so much to reach more people or faster? We have a very nice project in El Salvador of telemedicine. Salvador is investing $77 million in a countrywide project. It will be the first country in the world to have telemedicine for the whole population. That means 400 physicians providing care all the time. That means equipment in health systems that are connected, in health services that are connected to specialists for long-distance studies, with advice from specialists for those 400 physicians. That means that you have to build a new intelligent building with rounds amongst them. It's a very ambitious project, very nice, but most of all, it will take quality care to the last corner of El Salvador. It's a country with lots of mountains. The transport takes a long time. It will save lots of time. Cell phones already have 8 health measures: temperature, cardiac rate, arterial pressure. That's part of what will be used, part of the system that includes as Minister Rando said, artificial intelligence, images that will be taken for detecting a pattern of any problem. It will not be just that, but the system will advise the physicians with those symptoms and these images. It will recommend what the person might have. An artificial intelligence system according to age and all the data provided, recommending something that the physician will validate.
But the physician will then and there recommend a certain medicine, and the person will receive it with a QR code. They will go to the pharmacy. They won't have to travel to any center to look for the state pharmacy and so on. It's a system that includes the market, pharmacies. So it's a comprehensive system, and it conveys high-quality medicine to every corner in El Salvador and will make the use of the time of people very efficient when caring for their health, and particularly when they have to accompany another to care for a health issue. So I think we will obtain a lot of quality and equality for all. Some people may have an urban environment and health center and specialties close to the home with fast care, but this will be the same for all. So we will have a deep democratization of health in El Salvador, and I think it will be a sort of case that will be iconic in the coming years. In a couple of months, we will have the first pilot program, and soon after, we'll see something truly illuminating for the efficiency of investment and in the use of people's time to care for their health. Thank you, Pablo. There are many more other initiatives currently at world level that are well articulated with primary health care. For example, USA is strongly supporting this at global national level with One Health. How do you say it in Spanish? Una salud. Could you let us know a bit about the approach you're conducting and how is this articulated with primary health care? Thank you. As we said before, the region is recognized globally for health innovations and also when improving primary health care access. United States has supported a lot of work in the region, but in the past decade, we decreased this due to the issues in the countries. And with the pandemic, in the global community, we acknowledge the importance of strengthening the intersectorality between the environment, the veterinary sector, agriculture, and health. So we launched this One Health investment, and Pajo is a partner. She's mixing Portuguese and Spanish, a very important partner to us in this effort. And we launched the One Health program in 7 countries this year, and we'll expand this to 3 more. So we'll have 10 next year. This is very important work for us to further strengthen multi-sectorial collaboration among sectors, and we believe it will promote sustainability because we will try to integrate health among all the different sectors in order to truly approach all the intersections with the environment, agriculture, and human health. And a major component of the support is strengthening systems and working with local institutions, trying to integrate health and work in a more systematic, multi-sectorial manner. So we're very pleased with the expansion of all this support, and we believe that primary health care is also the basis for this sort of work. One Health is usually the start of a point of care where people searches for access. So we believe it is an opportunity to work more with primary health care. and improve the intersectorality between One Health and primary health care. And in the latter, it has several functions such as communication of risk, surveillance, working and strengthening health teams and community health, developing early warning systems, and improving guidelines from the primary health standpoint for other healthcare sources. Thank you. What you say is very important about prioritizing all this at health level, because when we speak of the strategic approach, we spoke of social determinants with community participation, intersectoral actions, and also One Health has exactly the same vision. And Vice Minister, if you allow me then, regarding intersectorality and funding, from the primary healthcare standpoint, how does Peru allocate resources for actions to approach the social determinants in health and health promotion to prevent diseases? And how does this negotiation with the finance ministry work to negotiate budgets to obtain more resources for primary health care? Yes, Peru has a 20-year experience with a comprehensive health insurance and funds 10%, uses 10% of its budget in health. The other 90% is through common resources, ordinary resources from the Ministry of Finance directly to the executive units, health networks and hospitals. But a very interesting fact is that the 10% that comes through the insurance, that is quote-unquote for variable expenditures, modulates the funding of the whole 100%. So, in that sense, we've been injecting more money in these 20 years through this insurance, increasingly more. However, financial resources for health have increased all the time, but maybe not so the results expected, because when we have this first level of resources through a capitation system, however, due to the weakness of the IT systems, we don't demand equal results as at hospital level. So this year, we've implemented some changes so that at primary level, we introduce new payment mechanisms such as preventive packages for life course in the primary level. We're quite sure this will modify things because we've improved the invoicing system that is more automated now. The system includes validation and medical consistency rules within the system, making the most of the open source software existing in the digital ecosystem. This will increase equality for health, giving more to those who need more. But as you said, we need interoperability with the other sectors in order to provide a comprehensive health approach. And this interoperability includes education, the social sector that carries out some health actions, particularly in children, mothers, and vulnerable people, agriculture, housing. So we try to have interoperability of information for decision-making and when designing projects, not only design, but the whole idea behind and the implementation and execution. So this intersectoral work to fund via healthcare through the different sectors based on health outcomes and impact is coordinated together with the other sectors. And it's one of the main reasons we've used when negotiating with the Ministry of Finance, because they say, as occurs throughout in the region, I'll give you more money, but what is the return? And in this case, we provide more financial resources to the regions at local level and receive information regarding impact, particularly based on chronic and degenerative disease prevention. And in a country such as ours, that is quite diverse, there was an increase in the countryside in particular of chronic and degenerative diseases. This leads us to realize that we've worked in an orderly manner, and we're currently working together with municipalities and regional governments, government and the state at territorial level, so that they provide their contributions. And for this, it is always vital to have an IT system based on international interoperability standards to compare ourselves with the rest of the world, and working according to a network rationale which must respond to national health policies. So during long periods, the Directorate of Financial Resources didn't have a network rationale and didn't respond to the national health policy based on primary health rather than hospitals. So this shift of changing the payment mechanisms towards a primary system at local level will be successful, and the partners at regional level, such as banks and NGOs, play a significant role. And we've made the most of some IT developments to improve invoicing and the comprehensive health system with international support. At present, we have a cooperation project with the government of Korea to improve the IT system in the comprehensive health system. And gradually we'll implement all the lessons learned during the pandemic, because it might seem that we are forgetting them very fast. However, we must be prepared for other events such as that, or worse ones. Thank you. Thank you, Vice Minister. Okay, I will propose something if you agree. Let's ask for questions and comments from the audience, because I think it's important to open the discussion. We have 15 minutes, okay? Good. Can somebody help me, please? Does anybody wish to make a comment or question to our panel? First, please, to break the ice, Olga. Please, say your name. In what language? Okay, in Spanish. Good afternoon, Olga Cabello, health advisor from the State Department in the U.S. My question is that the panelists describe or further elaborate sustainability of investment, because when we refer to investments on hospitals, for example, you create it, you provide equipment, and that's it. But the question is, if we're speaking of primary health care, I would like to hear from CAF, well, from everybody. Could you further elaborate on long-term investments? Because establishing a system demands continuous investment in the long term. So that's my question to you.
Thank you. Perhaps we shall take 2 or 3 questions. Mario? There is a microphone on this side. Thank you. Good afternoon. Mario Cruz from Pajojo in Chile. If the colleagues from the banks and CAP could tell us some examples where they have helped generate this case of needs of health ministries to mobilize funds for the transformation of health systems. In Chile, we are considering the need to have greater impulse to universal primary health care, but there are fiscal decisions that have to be made, like in every country, and the political time and the political opportunity of commitment that we have now probably will not exist later. How do we take advantage of this opportunity? Great question. Thank you, James. Thank you very much to the panel members. I wanted to react to the comment made by Pablo about the need to have that dialogue with the funding ministries, and we shall discuss that in the next session, so I apologize for jumping ahead. But you talked about the need for evidence and to demonstrate why it is important to invest in the first level. And that is fundamental. For instance, being able to show, as has been done in Chile, what is the cost of hospitalizations that could be prevented is an excellent argument because it gives a figure to the context and the dialogue. So indicators such as that one, for instance, coming from the area of service delivery and show that we can do things better seems fundamental in that dialogue. Could you expand on that? Thank you. Those are wonderful questions. We have 3 questions to the table, one on sustainability of investment, and then I think the 2 questions, one on case studies for investment, if I understood you right, and then evidence to justify more coherence for investments. So I think that Pablo from CAF is ready to respond. Well, I shall try. I start here, and then I will try to reach there and finish over there, more or less. Dialogue with financing ministries, economics in each country is always difficult because everybody asks for money for noble, relevant causes such as any other. There is an argument that doubles any Ministry of Economics. This pays itself. You tell that to a Ministry of Economics and they love it. And say, okay, that is what I'm looking for, that it pays itself. And that is what you've got to show, that this investment is self-paying because it avoids future expenditures. I go now to the middle of the room, sustainability. The issue, I throw the idea here to the floor. You will tell me whether or not you like it. The issue is that oftentimes to avoid future expenditures, you've got to spend on people who help us with our health. Sometimes you imagine that the investments on equipment and bricks and everything, and sometimes to prevent, we have to be helped to look after our own health. And this is people. And a minister of economics, the worst thing that you can tell him or her is that you need to hire nutritionists to avoid type 2 diabetes or hypertension or all the consequences of obesity, because you don't know how to convince people to eat better. And that is just advice, what I told about Ecuador today, community agents that also have the knowledge and to be close to people and may give an extra push to people. And that is also difficult because in order to avoid future investments, you've got to invest on people who help us today to avoid many future diseases. And because a lot of the change, and I will reach the 3rd point, a lot of change lies on people's heads. Years ago, a professor at Harvard was saying or telling how they had studied that you are from the USA, much of the health expenditure is spent in a person's last 20 days of life. Okay. So they saw what were the causes why they had to provide all those things to those people, and these were preventable diseases. And many people had been warned before. They made an experiment. People to whom a sort of problem was detected, they said, this is your diagnosis, these are your drugs. Do you think you will have a problem in receiving? No. Do you have an economic problem? No, no, no. A year later, they asked people if they were still taking their medication, and they said no. Why? Because after 1,000 questions, the basic conclusion was that I felt old taking all those medications. All that problem of health expenditure in the final days of life of a person lie here on one's head. They are habits. We have to consider how to get into people's heads to avoid that enormous investment in the final days of people's lives. And that is the hardest thing. We've got to convince ministers by saying this is self-paying. You've got to hire lots of people and get into people's heads and to see how to make them think differently, to behave differently. Today they think, okay, taking a pill makes me feel old. They have to think better so that they go on taking those pills. I believe the question on sustainability. Yes, I think the question about sustainability is a key one because at least in the bank, the directors ask first of all, and I'm not surprised because it is the treasury, the same. Okay, what is the sustainability? In the case of hospitals, although it looks like you say, okay, build a hospital, but then operating a hospital is a third of the investment, and you need the human resources. So if you do have this issue of every new investment, how will it be sustained? I believe there are very few investments that are self-paying. Yes, in the long term under certain assumptions. And I don't know, Federico was telling me that there are very few things in health that actually save money. Some vaccines, everything else generates health but requires investment. So if these conversations with the finance ministers, it's true when we talk about social determinants of health, we include things that compete with health investments, and they are necessary. So there will not be too many self-paying investments, and you have to present the case on how our investments, and here the memory of the pandemic that was mentioned for Peru, well, they're not investing well showed the cost, trillions of dollars, and the necessary investments are billions. We're not hearing. Maybe there is, yes, that was a sign, he says. About studies, we have carried out some recent ones, for instance, on what would be the savings for a country in using more generic drugs instead of brand name drugs. Questions that are quite applicable, that they have an immediate practical question, and many of the studies on benefit plans and how that would allow, with the same investment, to have much better results in terms of health. I think that is quite important, and something on evidence, because it's dying. They said, with the NCDs in Pajo, we were discussing that we oftentimes have the evidence, but we do not know how to present it. We have to think that we are talking to people outside the health sector. We have to provide good examples, concrete examples in units that others understand. There is evidence, but there is a lack of proper presentation of it. I have spent most of my professional life trying to convince ministers of economics that a health investment is cost-effective and sustainable. The pandemic had many bad things, but one is that I no longer need to try to convince ministers of economics on the importance of health. Now I think it is more an issue of directing investment to activities that are cost-effective and that allow the resources that remain limited may be used in a way that they show results and they reach most of the population, that they are equitable in the distribution of resources. And here I coincide with what Paula said. I think many times in health we are so devoted to details in nutrition, the micronutrients, in care to non-communicable diseases. We talk about the continuity of care, the promotion, prevention, etc. But for ministers of finance, that is over the top. They look at us like we were from Mars. So we really have to be able to better communicate why the investments in primary health care are cost-effective, and they will allow a better use of resources, limited resources, but resources that have to be directed to fulfilling the social contract that the government has with its populations. Sometimes we have to leave details in order to better convey information in a way that is understandable for people who do not belong to the sector. So, talking about studies, we are now carrying out studies looking at preventable deaths or preventable mortalities, and that is something that is clear for the Minister of Finance because we are talking about saving lives. It's not complicated. But if we go into all the details of care, no, that's not so, because I'm yet to meet one Minister of Economics from the health sector. So we have to speak their language because we cannot expect them to speak our language. On the issue of sustainability, we acknowledge the importance of evidence and to use this language to make a case for health investment, but we also think that it is important to go on working with local organizations in a way that is intersectoral to ensure that the efforts are integrated in other sectors. And the main actors are the ones in countries, NGOs, institutions, universities, governments. So we think that that is also very important to promote sustainability. Thank you very much. Vice Minister, you have the final word. Yes, thank you very much. But it is very important. I agree with all that you have said, and I will just mention an example. When the figures say what we want to say, there's no contradiction. We have 4,000 coronary patients, of whom we shall take 400, and we need so much money. And in 6 months, I will return them healthy and working. So, and if you don't give me the money, they will not be working, and you will not have taxation. And if that goes well, we'll take care of 4,000. And if you don't, we shall have 4,000 patients who are under your responsibility. Well, that is for funding. Unfortunately, everything went well, and he said, okay, do that tomorrow. In investments in a hospital or a building, I think most of the budget is in equipment, in technologies in the building, and we shall see whether they produce or not, because many times they become technologically obsolete without producing what they were supposed to produce. For that, an information system is fundamental so that we know how much equipment is working and what is the return they are giving while they are within their time of guarantees.
Because they have to work while they have the guarantee, because the property costs then will be very high. And speaking with the economists and the finance people, we must say, we invest this and this is a return. It wasn't self-paying. I invested this and it produced more than you invested. And perhaps health improves finance and even the tax basis you have. So at first level, it's harder to ensure sustainability. For this, I think it's essential to implement a good payment mechanism, and it must have a vision that is sustainable regarding equipment, for example. And this has occurred this week in Peru. We have a ministerial decree with simple biomedical equipment, scales, echocardiographers that may be paid with the universal insurance without much paperwork. So this makes primary health care work smoother and more streamlined. But if we have a good IT system, we will be able to show the productivity of investment and the return of funding in primary health care. It works with simple things such as ambulances. In general, maintenance of equipment isn't a priority for the local manager. Such as an ambulance, it goes to maintenance when it broke. So the IT system may define aliquots for funding for maintenance so that the investment is truly efficient and may have a return. Nevertheless, we are physicians, but it's easier to have a vision of the economy from the health standpoint as physicians, from the health point of view, as compared to high-level finances such as occurs for the Ministry of Finance. Anyhow, there is something before us. With this funding, we must first reduce suffering, fight against death, and finally be a healthier and more productive country. This has no price, and health will cost what it costs. Thank you. Thank you, Vice Minister, and thank you to all the panelists. I think we have had an excellent and very deep discussion. We have reached some conclusions, and there is consensus that we need more investment with a strategic approach of primary health care. So we care for the populations where they are, not only with public expenditure on health, with support of international partners. So it's a pleasure to listen to all these international partners that are prioritizing primary health care. But there is much more to make it effective and efficient. We must speak with the people who control the monies to make sure that what is obtained is mobilized in the interest of the population's health and well-being and development in the Americas. Thank you.
Hola, hola, sí. Bueno, muchísimas gracias.
Thank you, James, and all the other panelists. This session has been extremely enriching and diverse. I was just trying to organize some main issues, and I imagine three. One, this issue of the dialogue that has been present in most rounds, not only between health and economy, but also among donors and among the health authorities and donors, a dialogue ultimately among all the players that somehow are part of these processes to interpret the issues in the different contexts, formulating policies, and even among countries. This is one of the elements I believe is extremely important. That is cross-fertilization, to rethink how we may acknowledge good practices even in different contexts and not reproduce them elsewhere unchanged as a recipe, but rather in all cases interpreting them and bearing in mind different contexts. Second, much has been said about the object of our discussion, that's primary health care. And I won't repeat, but once again, although we do have a very strong vision that is clear regarding primary health care as a strategy, at the same time, we have a development of the different components of this strategy, even and increasingly with more and more clarity. We have challenges related to organization of services, but also related to the determinants, social determinants in the different populations, and now this need to include resilience. And funding has also been discussed in a very interesting manner, because we not only consider the different standpoints and cases, even with the Vice Minister of Peru with a specific case that he has experience and recognizes this element that is key to us, that coverage is one thing, insurance coverage, and it's different to guarantee effective access conditions, and that is a different path that requires consensus among the different players in the region, but that isn't easy to implement. I think that we will now have a session that is very interesting, at least from my point of view. This session, and I don't know if it translates well, it goes to the core of public funding, the operative and political dialogue position is part of the necessary articulation between funding and economy and health to have concrete instruments. It will be a pleasure for us to have with us Claudia Pesito, Regional Advisor of Health Economy and Funding here at PAHO. Claudia, please. Good afternoon. Thank you, Ernesto, for your kind introduction. The previous session, I think, has been a perfect introduction to this session now that is related with everything mentioned by Ernesto just now. At a certain point, we were asked, what do WHO and PAHO do regarding public funding? And this is essentially a matter of finance. And the reason is twofold. First, because when we propose to increase investment at the first level of care, this investment should come from public sources, as has been discussed in the previous sessions. On the other hand, because this demands the commitment, as mentioned by Dr. Barboso during the morning, the commitment to dedicate these resources and commit these resources to strengthening the first level of care, but evidence-based of how to implement these resources, because having more resources and investing more and spending more isn't enough if we cannot make it work better in order to have the necessary outcomes. And this entails a process specifically related with public money management, with a set of rules that decides how public resources are to be distributed within the system, and not only there, in the health system, but throughout the different sectors. And very particularly in the health sector, there are specificities because the health sector is characterized by uncertainty. Throughout this process of public funding management, we have the public budget at all stages, and the main presentation regards this. With us, we will have as a main speaker Helen Barrell, and I want to make a logistic indication. It will be in English, so please get hold of your headsets if you need translation. Helen Barrois is online. We also have different panelists who will comment on what she will say as part of the panel, together with other two speakers who will be with us at the table. So without further ado, I now will introduce Helen in English. I must refer to her CV as an economist and participant of the funding team in Geneva. Helen Barrois.
Expert at the WHO Department of Health Systems, Governance and Financing with 20 years of experience. She specializes in budgeting, public financial management, and budgetary space for health. And she has previously worked for the World Bank on public expenditure reviews and fiscal policy analysis. Earlier in her career, she worked as a policy advisor for the French government and various organizations providing on-the-ground support to public financing reforms for health in low and middle-income countries. She has extensive teaching experience, including the Sciences Po in the University of Geneva. Hélène holds a bachelor's degree in public finance and economics from Sciences Po, a master's in health policy from the London School of Hygiene and Tropical Medicine, and a PhD in health economics for the Center for Studies and Research for the International Development in France. So with no further introduction, Hélène, the floor is yours, and thank you very much.
Thanks a lot, Claudia, and good afternoon, everyone. Can you hear me okay?
Yes,
yeah?
Yes, we can.
Okay, very happy. So it's really my pleasure to be connected actually with all of you this afternoon. I wish I could travel to Montevideo, but unfortunately I was unable to do so. But it's really my pleasure to be with you, and I hope it will be a very interesting session. In this presentation, if the slides are moving, which is not the case, so give me 1 second. Okay, let me try again sharing my presentation. Okay, so in this presentation, I would like to review some of the critical public financial management bottlenecks for effective PHC financing. And I would like also to discuss, even more importantly, some policy options, some concrete solutions that can be introduced or accelerated in countries as a way to actually overcome those challenges, those PFM challenges that Claudia also mentioned in the introduction. I just wanted to say that this presentation builds from an extensive program of work that is being developed in the headquarters of the World Health Organization in Geneva, but it does also directly comes from excellent country reviews and really a program of work that is being developed also at the regional level by PAO colleagues. And so this presentation is really connecting on those two streams of work. Okay, so as Claudia said, I think this presentation directly builds from the previous session that you had on health financing and the role of international and external resources. But here the focus is really on domestic public financing for PHC. And we know that in general, in low and middle income countries, domestic public resources have been really a driving source of funding for primary care in most low and middle income countries. And this is especially true for upper middle income countries, as you see here on the graph. So in upper middle income countries, actually public funding represents the majority of the sources of financing for primary care services. And we know that upper middle countries actually dominate Latin American or the region, the Latin American regions. So if this is the case, then as Claudia explained, the processes, the rules, the practice that do govern then the allocation, the utilization, and the monitoring of public funding, that is to say, public financial management or PFM. So this set of processes then really play a critical role for this agenda of effective financing for PHC. But the problem is that in most countries, in most low and middle income countries, PFM systems do not necessarily function very well, right? We have bottlenecks at each step of the budget cycle. And those bottlenecks will then impact the effectiveness, the efficiency of primary care. As far as budget formulation is concerned, which is the first stage in the budget cycle, so in terms of budget formulation, the concern is that in general, budget allocation rules do not allow to prioritize certain services or certain areas like primary care or the level of where the care is provided. So those types of formulation are rigid. We cannot reallocate. We cannot really align the budget with the needs or with the service needs that are prioritized in a society. If we go to budget execution, often in countries, spending protocols are very complex. They include multiple layers, they are cumbersome, the disbursement of the funding is slow and very complex. And in several systems, primary care providers cannot access directly public funding. So it's very difficult for them then to manage public funding in a way that is actually aligned with the needs from a primary care perspective. And then third, in terms of budget monitoring and accountability, in several countries, we know that accountability systems do not actually enable to monitor both the financial performance, so how much was spent, but at the same time to monitor also the non-financial performance. So what was achieved actually with the level of spending that was done for primary care. So very fragmented and limited accountability at the end of the day. If we go deeper on budget formulation, we know that budgets that are traditionally formulated on the basis of inputs, and I'm displaying here an example where you see actually a long list of detailed lines and detailed items, right? So with this type of input-based budgets, it's very difficult to prioritize. Both budgets are quite rigid. There is no sufficient flexibility to do reallocations between those lines. There is also no clear link with outputs. And something also very important for financing PHC, those types of budget do not allow to budget and spend for cross-sectoral activities. If I want to spend for the non-service part of PHC, I cannot do it with such a budget. Going now to the problem a little bit deeper, the problem of budget execution. We know that budget execution in the health sector is also problematic in some countries. Ministries of health do not spend fully the budget allocation that is allocated to them at the beginning of each fiscal year. And so we know that this situation is linked to some issues that are directly linked to what is happening during the budget execution phase. So when the budget is actually spent, the release of the funding is late, it's not released in full mode, there is deprioritization of the sector in the middle of the year. So those are quite known PFM causes of low budget execution in the sector. But please note also that there are some health-specific causes that do drive also a low level of execution in the health sector. And here I just wanted to flag that the fact that providers, including at primary care level, that do have limited financial flexibility and autonomy, in those situations, those bottlenecks can actually contribute to lower the level of budget execution in the sector. So budget execution is a complex issue. It's related to those causes that I've just described, that is happening during budget execution phase. But we know also that there are some upstream causes. And again, the way the budget is formulated is likely also to have an impact on the ability to spend it, right? So budget formulation is also impacting the level of execution. And we know also that the way the budget will be controlled and monitored can also have an impact on budget execution. So budget execution in the sector is really an ecosystem, and we need to look at it in a very comprehensive way to be able to tackle the priority actions. The last challenge that I wanted to mention in this presentation before moving to some concrete policy options is these questions of the rigidities in human resources management. This aspect is somehow indirectly connected to PFM rules. And the point that I want to make here is the following. In my view, in most countries of the region, primary care facilities are not necessary or not sufficiently involved in the planning process to be able to define the needs in terms of staffing, right? Not directly involved, not sufficiently involved, then staff are allocated to those facilities without necessarily a good alignment with the actual needs in terms of services and response to population needs. The other thing that we often observe in countries, and I know this is true also for this region, is that at primary care facility level, actually the staff is not really able to hire locally. So when there are emerging needs, new needs that they need to cope with, it's very difficult because there are some rigidities in the rules that are in place. It's very difficult to hire, to contract new staff. So really a set of rigidities that do also affect the effectiveness of PHC financing and ultimately PHC outputs really at the provider level. So what can we do? I've just mentioned earlier that there are some bottlenecks that are very common to the countries in this region, but it's also true for other regions. But I'm very happy also to present some concrete policy options but can be introduced in countries. And I know that countries of this region have actually started to seriously overcome and address some of the PFM bottlenecks that do affect the financing of primary care. So first of all, what can we do in terms of budget formulation? We saw earlier that budgets that are traditionally formulated by inputs following the economic classification are problematic, right? They are problematic because we cannot really prioritize using this type of formulation. So some countries have started to transition to an alternative form of budget. It is called program-based budget. I'm sure you're already familiar with this new form of budgeting. I know that several countries in the region have actually started this transition. And so countries have been transitioning to this alternative form of budgeting as a way to prioritize budget allocations. We know that PBB, program-based budgets, it's actually a tool that groups inputs together around policy outputs, and the way they are grouped is through programs or programmatic envelopes, right? So through this approach, if you want to include a budgetary program for PHC or include PHC at a lower level of your program, it's possible. And then it gives more visibility, it gives more priority to PHC goals, to PHC services through this approach, right? So it's really it's really a tool to help you prioritize your budgets and really to serve the goals that you want to achieve. In a study that we are doing currently in WHO, we wanted actually to understand better how actually countries have included primary care or PHC services in PBB structure, in program-based budget. And so what we are seeing through this study is that, unfortunately, most countries that have started to introduce PBB, so most countries have actually not used PBB strategically to prioritize budget towards PHC. What is actually happening is that most countries that were actually included in this review, most countries have actually included PHC in a very fragmented way. So PHC is included in various budget lines, a little bit here, a little bit there, a little bit there. So at the end of the day, it doesn't improve the visibility of PHC in budgets. It doesn't improve the priority of PHC in budgets. And in some cases, they actually present by disease. So PHC then appears in a very fragmented way and scattered way through disease-oriented programs. There are other options, as we show here, there are other options to include PHC in PBB, so we should learn from that. But now what I wanted to tell you is that countries have not necessarily chosen the most effective way to use PBB to serve the PHC goal. And especially the point that I wanted to make in this slide is that specifically when countries have chosen to design their PBB along the lines of disease-focused programs, as this is the case in Peru, the example that I'm showing here. So in that case, then PBB exacerbates, potentially pre-existing, but exacerbates the financial fragmentation that we often see in health system financing. And ultimately, it can also drive inefficiency at the provider level, because imagine if you are a PHC provider, you then receive sources of funding for PHC services through these 9 programmatic funding channels. So it's not very effective and efficient. So what is more recommended is really to try and use and design PBB in a way that could actually much more support integration and an integrated approach or integrated service delivery model with obviously PHC at the core, but then connecting it with the other levels of care. So to do that, you can have a budgetary program, which is, for example, a budgetary program about access to care in general. And then you can have sub-programs, the first one on primary care, the second one on another level of care, and then making sure that you set up some links and incentives so that within the budgetary envelope, the different levels of care can be coordinated from a financial perspective. Even in countries that have actually designed PBB in a better way, so in some countries, they have actually opted to have a primary care program. This is the case in a country in Africa, Gabon. This was also the case in Kyrgyzstan, another country in Eastern Europe, Central Asia. But the point that I want to make here is that even when PBB is well designed to serve the PHC goals, political will is still needed. You see here in the case of Gabon, okay, they do have a budgetary program for primary care, but they have allocated so little in comparison to the other budgetary program, so that at the end of the day, it's not really meaningful in terms of the level of prioritization that they allocate to primary care, only 3% of the total budget program of the health ministry, okay? And Kyrgyzstan was able to do better. Well, you see that it's close to half the budget and the spending of the Ministry of Health. Last point on PBB is related to the fact that PBB is not only a change of budget formulation. To really work well, PBB should actually be accompanied by a change in how the funding is dispersed. Because if you change only the way the budget is formulated, but then if the funding is still dispersed by inputs, then it doesn't change anything, right? And unfortunately, this is what we are seeing in most countries. When we did the study that you can see on the right-hand side, most countries that have actually engaged in PBB reforms are still at the pilot phase. So they change the way the budget is formulated, but they don't change the way the money is dispersed. And at the end of the day, it doesn't count from a PFM perspective. The other point, which I think is an important requirement when countries want to consider introducing PBB, you need to really think in terms of how to set up a robust performance monitoring framework that would somehow allow you to really secure accountability, because obviously with PBB, you give more flexibility. So you need also to set up the accountability system that would allow you to track how much was spent, but also how this money was used to serve which goals. And in the case of PHC, what type and what quality of service would be delivered at the primary care level. This would require to have robust data systems. So data system both for the financial performance, again, but also a data system for the non-financial performance. And the point here is really to set up systems that could speak one to the other, really showing how much was spent, but also what was achieved with the PBB resources. Connecting now to what can be done in terms of budget execution. So you remember the matrix that I shared earlier. So obviously there is a set of generic PFM features or components or aspects that could be improved, and those things would certainly improve the level of spending. But the point that I want to flag here or to highlight here, which in my view is really critical both to improve the level of spending, so to improve budget execution performance, but I think it does also impact the quality of services. And this point is really about the level of financial flexibility that PHC providers can have at their level, right? And so I think this is a critical point, and this is often, I would say, misinterpreted, especially from the PFM community. I think we need to collectively recognize that the financial transactions that are actually happening at the PHC facility level, in most countries, they are very small in value, very small in scale, right? So somehow the risks are quite limited. So those providers should be really given greater discretion over the running costs, really the ability to spend according to the evolving needs that they are facing. And I think those processes, those spending processes can be streamlined, can be simplified in most cases, really to allow the PHE providers to manage their funding, really to serve the needs as they emerge. Obviously, flexibility goes with greater accountability. I think this is really those two notions and concepts that should be envisioned and conceptualized and designed in PFM reforms really hand in hand. So we advocate for greater flexibility, especially at the PHE provider level, but at the same time, stronger accountability systems should be put in place, including at facility level, okay? And the point that I want to, or the example that I want to flag here comes actually from South Africa. I like this example because in the case of this country, they were able really to consolidate financial and non-financial performance monitoring. So what I explained earlier, the need really to combine, consolidate, harmonize, and make sure that those two streams of performance monitoring do actually connect and speak to one to the other. So what they did in South Africa, they really set up a consolidated system to monitor the level of spending by program and by sub-program. You see here actually the example of the budgetary program for PHC, and you see how much they spend for the different sub-programs of this PHC budgetary program. And they have actually the exact same table to show the output. So the number of services and a range of different indicators and targets that they had set up for this PHC program. So really connecting the two phases of performance monitoring really in an integrated way. So I find this example really inspiring for other countries. The last point that I would like to make is related to the subnational level. I've been speaking quite a lot about PFM processes at the central level to improve budget formulation, to improve budget execution. We spoke also a little bit about PFM at the provider level, but there is a level that I think that needs also some attention and careful attention, is what I call here the subnational level. It can be the provinces, it can be the districts, the counties, whatever is it called in your country. I think what I've been observing over the years is that we do PFM reforms, we do health financing reforms, and then there is also a process of decentralization. And what is happening in most countries is that those three streams of reforms are inconsistent, they are not coordinated well, and sometimes they result in conflicting incentives for the subnational level. So my call here is really to envision and consider these three different streams of reforms in a much more consolidated way, and really to be able to reconcile those three streams of reform for more equitable and efficient spending on primary care. So to recap, what can be done from the PFM side, from the PFM perspective, to promote and support and enable primary care financing. I think the roadmap is quite simple. I just wanted to recap it here with this graph. The first thing is that we need to have credible budgets, credible budget formulation that is planned on a multi-year basis. It's very important in terms of predictability. But we need also to have what I explained in terms of this level of sufficient flexibility, potentially through PBB, to be able to make some reallocation within the fiscal year. In terms of budget execution, we need much more simpler processes. Funds need to be released on time, in full mode. And another point that I think it's really critical in terms of effective budget execution from a sector perspective, we need to have providers, PHC providers in our case, that are empowered. They need to be able to access public funding. They need to be able to manage and report on those funding. They need to be empowered. Last, in terms of budget reporting and accountability, we want an accountability that has those two phases, two components that I explained earlier. So really connecting finance and operational performance. We need to look towards outputs, not inputs. It should be transparent and it should be digitalized. In terms of the priority actions that your countries can consider to move closer to effective primary care financing, the first thing that I want to reiterate here is that there is a need to accelerate for countries that have started already, or introduce for countries that have not yet started. So accelerate or introduce new forms of budgeting. Program-based budget is a way to prioritize your budgets towards primary care. But as we saw, PBB doesn't work if you don't pay specific attention to the design of your budgetary programs, right? So consider really PHC within broader budgetary programs and make sure primary care is then connected from a financial perspective with the other levels of care. Second, make sure that you provide sufficient flexibility in the way the public funding or the public resources can be managed, in particular at provider level. It's too bad if we have a very well-designed budget with funds that are disbursed on time, but then PHC providers don't have access to this funding, right? So you need really to provide direct access to public funding for PHC providers. And then those providers need to have sufficient flexibility to be able to align those resources with the needs, with the service needs, or with the needs that do match with the needs of the population. Last, as I said, flexibility always goes with strengthened accountability, and accountability that covers the two phases, finance and non-finance, but which is also looking towards outputs. For all those different PFM reforms, there is a need to engage between health and finance. It's about a joint dialogue. Nothing that I've mentioned earlier can be done only on the health side or only on the finance side. It's really at each step of the budget cycle, and for each step of the design and the implementation of those reforms, it's really about dialoguing, communicating, and really working jointly between health and finance authorities. To close, I just wanted to highlight a set of resources that we've put together. So we do have a platform. You can access it if you type on Google pfmforhealth.net. It's a WHO platform, and you will find a set of, I think, roughly 200 resource materials that do cover what I've mentioned in terms of budget formulation, but in much more details, with several case studies that have been done in this region, also a lot of resources on budget execution and accountability. Thanks a lot.
Muchísimas gracias, Helen, por...
Thank you, Helen, for your presentation. I'd like to highlight some of the aspects, the main points that Helen said in her presentation, and this thoughts of why we need to talk about public financial management and the budgeting process and cycles. And these resilient proposals for universal health care is based on the strengthening of the primary health care, and it requires a better public investment. And we find ourselves with many challenges about the different different parts of the process, as it was well pointed out by Helen, and also in the accountability process afterwards. Therefore, there are certain bottlenecks that may occur of how we can better use the resources in the provider level. How can you redistribute the resources according to priorities and the needs, which are often changing depending on the population that you are working with. And of course, it has an impact on the outputs and the results. And so, therefore, the importance of the dialogue and the different factors of the political economy, because resources are limited. So how do we prioritize this based on the evidence that we need to have to be able to make a case for investing more in primary health care? Now I'd like to invite the members of our panel. I think they're us in the auditorium, Dr. Bernardo Bartorell and Dr. Miguel Abreu. And while they come to the stand, I'd also like to introduce you to Federico Lais, who is very patiently waiting for us on the screen. You can see him there. Hello. Hello, everyone. A pleasure. So briefly, I'd like to introduce both Federico and Bernardo and Migueas. I'd also like to thank them for their presence. Federico is the head of the WHO team, who's in charge of health statistics and health informatics oriented towards people and primary care and the impact of climate change in healthcare system. He is the director of the Paris Survey, which is a multinational OECD pioneer program for developing primary care and healthcare systems depending on the experiences and responses of the users. And he is also supporting implementation of certain implementations of changes in Europe and the Caribbean. Federico is also well known in this region. He's worked with the Inter-American Bank and has working with different loans, and is currently leading a research program for Latin America and the Caribbean. Bernardo is a doctor surgeon from the University of Chile, and Harvard, and is currently working in the University of Santiago and Universidad Andrés Bello, and he is the director of primary health care in two important areas in Chile and in the metropolitan area of Santiago, and he's been the regional secretary for a region, the south of Chile, and has been a director of management in primary care in Chile. He is currently working in the Ministry of Health and is the coordinator of the healthcare reform. We also have Miguel Abreu, who is a physician, specialist
specializing in gynecology, has a master's in management and healthcare management and public health, and is currently the director of the primary healthcare system of the Public Ministry of Health in Paraguay, and the director of a research center in population studies and demography and public health. He was previously the regional director of the other listed hospital and generated a technical team for integrated systems in healthcare in 2019. So without further ado, we would now like to consider the presentations that were exposed by Helen. We'd like to ask them to respond or react quickly to this presentation, and then we will have a time for questions. Federico, would you like to briefly comment on Helen's presentation? We would thank you. Thank you. Thank you, Claudia. Welcome, everyone. I would have also very much enjoyed being with you, but that was not possible. Alongside Helen and other colleagues, we have several work groups, global funds, and we've created a network, which is the Sino Budget and Health Officials Network. And my colleague Chris James, which is the director of that network, part of the OECD, and he was involved last week at a meeting with Helen, talking about the importance of bringing to the same dialogue ministries of health and finances. And we need, and I believe in the health sector, we need the vocabulary, the tools, and the tools to be able to have a better dialogue in this front, but not only considering that the budget is a specific one and it can't be influenced or modified. So I think the points that Ilin was bringing to the table, I think they're very interesting, because the healthcare sector needs these tools and needs this vocabulary to be able to achieve something which is more substantial and not just saying we need more money. Thank you, Federico. Bernardo? Hello, everyone. Thank you very much for the invitation. It's a pleasure to say hi to all of you and be here as a panelist. I also am grateful for having this issue brought to the table, which has a high impact. As you heard of my CV, you highlighted my time managing different healthcare teams in different parts of Chile. And when you live the budgeting constrictions in your own skin, and you think that there are certain structures that are unchangeable, which cannot be modified, so it's definitely important to bring to the table a discussion which may be complex or not very sexy, but what I do think, there are certain things that are involved in the budgeting cycles and processes may make things easier or more complex for those who actually have to carry out healthcare on the ground. I think it's very important for us to remember that the proposals which are made to the local management, we can go work hand in hand with the different mechanisms. These are financial mechanisms which are relevant. They're not the only ones, but they can also interact with those things that will interact with public policies. Remember, Daniel, I find it difficult to introduce economists. They're often not very welcome in these sorts of meetings, but thank you very much. Welcome, everyone. For us who work in primary healthcare, budgeting is very important when we want to reach universal access. And it's very important to have a united language. Often work is plagued by administrative and bureaucratic issues, and here we are bringing together technical and administrative points so we can give an answer to the needs that the society has. I agree with Helene's presentation. It was short but to the point and very interesting. We need to talk about the budgeting of primary health care, so we will strengthen our systems. Thank you very much. Now I'd like to have a time, moving on to the next section, to be able to definitely focus on and look at each one of our panelists. The first one will be Federico, and we have a few questions for him with regards to the role of the segmentation and fragmentation of the budget, and in order to obtain better efficacy in the budgeting and in our healthcare systems. We know that the context, macroeconomic situations after the pandemic and other global dynamics, we know that this is going to be complex. It is we're not necessarily going to be able to have the resources that we had during the pandemic. So we need to be innovative, and we need to see how we can overcome these restrictions. So the first question, Federico, is considering the importance of public funding for a approach based on primary health care. What do you think are the options that are existent in this non-growth era for economically based on the global economy and in this region for the coming years? Thank you, Claudia. I think that in a discussion about efficiency and efficacy, we want to talk about underspending or bad spending. I think a report we had in 2017 by the OECD, and then in 2020, a Latin American who talked about misfunding or bad expenditure, the operational expenditure, and in governance of the systems. If we talk about the dialogue, we need more funding and resources. The first answer is going to be, show me that you are spending correctly or adequately. And so having a clarity of where are the inefficiencies in the system, that is very important. I won't go too far into detail, but I want to highlight this as an initial point. The second thing, and Elaine mentioned this briefly, we need to rediscuss human resources in primary health care. When we talk about budgeting and talking about more resources for primary health care, and considering the important human resource lack that we have in Latin America and the Caribbean in particular, it's important to consider other terms for management of human resources. Some basic numbers in Latin America and the Caribbean compared to the OECD. There are 2 doctors per 1,000 versus 4 per 1,000. There are 4 nurses per million versus 10 in the OECD. In some countries, it's even more complex. So, for example, in Colombia these days, it's very interested in having a reform based in primary health care, but there are many different issues. So we need to rediscuss the human resources and the budgeting allocations. But moving on from efficiency, another element which is is important on prioritization of the public funding. So we need to talk about mobilizing funds for primary health care.
First, then, let us start with how to mobilize more resources for health within the public budget. In that case, most countries have little room, be it OECD or Latin America. In the form of 15% of the public budget approximately goes for health. And in many countries, this is the largest part of the budget. In Latin America, it varies. Costa Rica, Chile, 25, 19. But other countries such as Mexico and Brazil don't have this possibility of increasing the health share in the public budget. However, there is another prioritization I believe is important, and that is prioritizing PHC in the health budget. And it is my perception that there is a large room to redistribute health expenditure, investing more in PHC. But, I can't leave aside this matter of definitions. So what is a health expenditure and what is a PHC expenditure? In our view, PHC is 13% of health in OECD countries. In Brazil, 16%, Canada, 11%, Costa Rica, 15%, Mexico, 16%. I know that WHO and PAHO consider another definition, that is Brazil would spend 40% in PHC, Canada 38%, Chile 50% approximately. And my question is, if a Minister of Health tells the Finance Minister, I need to invest more in PHC, I need a larger budget for PHC, and the Finance Minister asks, how much do you spend in PHC? How much of the health expenditure goes to PHC? They answer 40-50%. So the answer from a finance minister would be, I think that's quite enough. So I think it's very hard to say that the health systems are hospital-centered, spending 40-50% on PHC. In that case, I think it's very important to have a better rationale to ask for more money for PHC. And last, the management. In this dialogue with finance, it's important to have some elements. Health needs to reach them with connections for long and middle term for health expenditure, to have budget programs, as Helen mentioned, based on the health sector goals. But oftentimes the health sector doesn't really discuss clearly what is a framework for assessment of performance of the health sector. So in OECD, we're discussing this subject very much with WHO health system performance framework. And it's very important that we have clear performance indicators contributing to the discussion, saying, I want more flexibility in resource management, but if those indicators or data are not available and easy to show, it will be quite hard to manage to have a conversation on these terms. Thank you. Federico? Well, much to think about, particularly regarding efficiency. It's something that sometimes makes many people uncomfortable. We've discussed this very widely, but the idea is to spend better and more on health. Now, I would like to hand the floor to Mikea, shifting the subject to something Federico mentioned about the role of incentives to integrate care services, and that seems the appropriate proposal on how to spend more and better. We are aware that public financial management, as Helen mentioned in her own presentation, may generate significant bottlenecks here. So, my question is, Michael, could you reflect upon how do you think that funding may contribute to the strengthening and expansion of a person-centered model of care that is multisectorial, where the social determinants of health play a main role, knowing that it's hard to reconcile these multisectorial budgets? It should be a logical consequence. Well, as a colleague said before, I think that primary health care is resilient. We apply strategies appropriate to the needs of individuals and communities, but oftentimes the administrative part is more closed and rigid at the time where we must consider how to retain our human resources in the places where we've managed access or reaching communities. We have examples in Paraguay of excellent human resources trained in PHC, but because they didn't remain in the community, well, we run the risk of having a displacement of human resources. So I think it's time to gather all sectors and the funders and people investing on primary care. That is not spending, but rather expenditure. So we must link all this, and resources must remain at local level so the people with strategies have the timely and appropriate tools. Thank you. Thank you. Your comment reaches the bone of or core of PHC that has this very important component in human resources and even in the funding, because 100% of the funding could be human resources without operational resources or input for other activities. Now, we would like to ask Bernardo about another interesting topic that Helen also mentioned in her presentation regarding decentralization. We are aware that in Chile, PHC is clearly decentralized and is under the responsibility of municipalities. But this also creates an interaction between the capacity to predict and the timely funding that are necessary elements in funding. What do you think, Bernardo, are the major advantages and challenges from the funding standpoint of this decentralized municipal system as you have in Chile for PHC? Indeed, as you said, in Chile, PHC is municipal since 1981, and since then, to date, we've had an interesting dynamic of pros and cons, or challenges, as you said, for this manner of decentralization of PHC. I think it's an interesting case to analyze and observe. In the first place, I would say that there's a risk when you decentralize, in this case, make it municipal. I must highlight that it isn't 100% municipal. It's close to 90% of the population that is under this scheme. But there is another percentage that receive PHC dependent on the provincial or regional health centers. So we have both sides, but it's mostly municipal. And there we observe issues with quality and equity or equality of the expression regarding PHC, with municipal weak and sometimes very strength management teams, so there are gaps and issues of equality in this distribution. And another con that creates suspicion is a poor use of resources, devoting them to other sectors or needs in the municipality, or in clientelism or corruption at local level. Although those cons must be compensated and analyzed in the light of the pros. And these pros are, well, we've mentioned the social determinants of health, and it's the municipalities that have most of the local management in the territory in their hands. And when we consider primary care in Chile, it's territorial, and that's closer to the social determinants of health. So we've seen an opportunity there to conduct this more integrated intersectoral work. It's not automatic, it requires an effort, but it is an opportunity to work together with other sectors. We've also observed that the local levels, majors and so on, are more sensitive to the needs of people, and here there is this capacity of tailoring PHC to the territorial realities. And another pro that is not so clear, perhaps, is that when we separate the budget from the hospital budget, we somehow protect the PHC budget. And this is important because for those who have been in places with PHC together with hospital care, we've seen this preference to allocate resources to more urgent matters in hospitals, and therefore to remove funding from primary health care. So this manner of clearly separating the PHC budget is quite interesting when make it municipal, although there may be other manners of separating it. And another pro that in my view is the most interesting is that at a certain point in Chile we have 346 municipalities, and we gained all these allies that are very relevant in their territories. The majors become allies to the health system and of PHC. And this is expressed yearly in the budget discussions. So when we speak of the possibility of formulating the budget, in the case of Chile, majors become active and mobilize when the funding is per capita mostly, and it flows in this per capita basis. So when it increases very little, the majors become active, they contact parliamentarians, they activate their networks at all level in the whole political spectrum, and generate this drive for an increase of PHC in time. So in the past years in Chile, we have observed this process that is a bit unpleasant for the ministerial authorities, because you have the majors coming requesting more resources for PHC and generating some sort of protection and encouragement of PHC that is valuable for the health system. Well, that is what I could say briefly about the pros and cons of having a municipal in Chile. Thank you, Bernardo. This experience has many years and has other contributions, because you have a family very manifest health plan, so people are aware of the fact that they may make claims or not. That's another pro when adjusting the different levels of resolution on the per capita basis. But, well, I won't further elaborate. It's a very technical matter. I would like to go back to Federico regarding segmentation, and I have another difficult question for you. From your standpoint, we're aware, Federico, that there are hurdles, structural hurdles in the region regarding this coexistence with the social security funds that are quite complex, because that budget, these funds are not part of the budget cycle, but are outside the budget. So you have this duality within the systems that live together, the public sector, public health sector, and social security, and this definitely has an impact when we want to strengthen the PHC approach. So what do you think are the main challenges related to this manner of organizing at structural level with these two poles in our region?
Thank you, Claudia. You always send me the difficult questions. As you said, healthcare has a budget which is independent or separate from the governmental budget in certain countries. Not in those Bismarck models with a social security model, or even in certain systems which are decentralized. My vision is that this doesn't determine a priori that certain healthcare systems can't have an important focus on primary healthcare, or they can't have a strong primary healthcare. Actually, I think that I can give a few examples of the OECD countries. So, for example, the Holland or Israel, Slovenia, these are countries which have a social security model with a Bismarck model, and they all have a strong tradition of primary healthcare, and they're some of the best examples of primary healthcare in the OECD region. And so they're models of social security that have particular budgeting models. They don't necessarily mean it will be a weaker primary healthcare system. There are other examples of other countries which have national healthcare systems, like Spain or Italy, but also have a decentralization process, Spain and Italy. And in those countries, they have a strong tradition of primary healthcare systems, but there are very important regional differences, especially in Italy. So I think that it doesn't necessarily have to be an obstacle. In the Americas region, or in Latin America and the Caribbean, the situation is more complex because of the great level of inequalities that we see in our societies, depending on financial reasons, education, and that generates a fragmentation of most of those systems. Also, in those cases, there are other examples. So, for example, Costa Rica has a social security system, but it's not fragmented. It has a high coverage through social security, and an important part of the funds are managed outside of the general governmental budget. Not only for healthcare, but also for retirement funds. And it has a strong primary healthcare system and tradition. So it doesn't necessarily, having a social security system doesn't mean it will be a weak primary healthcare system. But I think the situations which are more challenging are those systems which have two levels. For the poor people, you have non-contributive healthcare system of the Ministries of Health, and for middle class, a social security level. So it's the case of Peru and Mexico until not long ago. And in those cases, the problem is not necessarily the focus of primary health system in these dual systems, but there's an important difference of the contributive systems. So these countries, the capita, which has the non-contributive part it's very different from those who do have the social security. So that is the main challenge. Another point which I think needs to be mentioned is considering COVID and the pandemic, the systems that had a social security in emergency and crisis time may have important problems. And so in primary healthcare was totally excluded from a lot of the discussions about the pandemic in these countries with social security system. And also in some countries where the primary healthcare providers that needed a fee for service, they didn't have for service and they didn't have any income for quite some time. And so here the coordination of public health system and including the primary healthcare, for me, all these elements aren't necessarily barriers to having a strong primary healthcare system and having part of the budget from the social securities. I think that certain reforms in Latin America and the Caribbean are a bit worrying because they're looking to generate systems that have a strong healthcare system. With primary healthcare, they think it needs to be a national healthcare system. I don't think it doesn't necessarily have to be that way. And in a discussion like we're having here, this Alliance for Primary Healthcare Systems, and we need to understand the context of each country and their strategies. I think the vision is there isn't a single solution for everyone. Every road is going to be different depending on the country. And consider, of course, the fragmentation challenges and the inequalities that we have in our Latin American region. Thank you, Federico. Definitely the one-size-fits-all isn't necessarily true, and the discussion needs to consider the context and its relevance and to have a greater impact. You touch on an important subject here regarding inequalities, and now I'd like to talk to Miguel. In the last few minutes, I think we have time for one question. Considering these barriers for access to healthcare system, especially primary healthcare, the financial barriers with co-payments, geographical or restrictive systems, connectivity and high demand with digital health. What would you think is the role of financing for a strong primary healthcare system? I think the role that financing has is to minimize and in some cases reduce the gap in inequalities within the countries, not only within the region, but we need to integrate and bring in the people who are involved in practicing an everyday like to have a greater inclusion in financing. It needs to be empowered and it needs to be timely. And both the Inter-American Bank and World Bank, who are working on strengthening all these tools for not bureaucratic, more flexible tools. So when we have all these different requisites and conditions that the banks are demanding, we think it's difficult, and it looks like it's the primary healthcare that can't give the solutions, but it's often not that. We need to eliminate these barriers and consider the different dependencies such as the local ones. So to have a stronger and resilient primary healthcare system where the community is involved, it needs to be involved in financing as well. Thank you very much, Miguel, for this point of view. This is a view such as Paraguay, which has a lot of those barriers that have been described. Well, now like to go back to Bernardo and pick up the issue that Helen mentioned, and it was also talked about in the previous session. The budget is a process which is strategic and participative, where there is a planning for healthcare, or it should have a role, which is essential. And so the budget should answer and respond to the planification and planning of the healthcare system. We also expect that the different players involved and stakeholders involved in each sector should express their voices and be with regards to their needs and the population's need. Could you share how this process of approving a budget in healthcare is carried out based on these principles in Chile? We know that recently there was this discussion on the budget was quite complex. How do you navigate this discussion with the reform and the considering universal access to primary healthcare system? Yeah, thank you. Connecting to the answer that Federico gave earlier, in Chile there is this dual system. Chile is 15% of the population with the highest incomes have a social security of sorts, badly regulated perhaps, and 80% of the population has a system which is a Bavarian model, which is the national system with a national fund for healthcare. And so the first part of the system, the social security, has very little discussion of prevention and primary healthcare. And one of the points that we're trying to move in the direction of universalizing primary healthcare for that sector of the population, so it's a common level of healthcare for everyone. And so how do we create a budget in Chile? We have two levels. On the first way you have the national level and then on a local level. And the local level has a budget which is assigned per capita, depending on the number of people who are registered, and a few other elements, and a long, complex program-based issues. And so we have these extremes that Helen was describing with a program-based budgets, especially by diseases, which is fragmented and inefficient for primary healthcare. So these words that you shared, Helen, have been very relevant to us in the practice, clinical practice. The rest of the budget is established on a local, and it's based on a local government, and all the political actors are involved and determine how much of the budget is going to be allocated per capita, which is the most flexible output, how much is going to be assigned. There's quite a lot of flexibility here, which is good because it allows the municipalities to determine things which are going to be approved by this governing body. But it also has a problem that there's so much flexibility that we have seen an over expenditure in human resources. So you'd expect that 80-70% is going to be human resources, and we see 90 or even 99%. And so sometimes they spend all the per capita in human resources, and the rest of the procedure is financed through the different programs, which is another source of funding. And that is also a problem of this over flexibility. And that's where I want to say we need to have better rules or norms of how we allocate the budget. So that expenditure on human resources, of course, is something public. How are you going to interpret this on a with the healthcare goals and the incentives to the workers? And in Chile there's a certain objectives and incentive for workers, which also generates a lot of other problems. It has its benefits, but it does generate problems too, and this is part of what we are reviewing in this process of reform currently. as how you can improve, and Helen mentioned this in her presentation, in the framework of the objectives of the healthcare. And so each country needs to elaborate this in a harmonious way, in a non-fragmented programs way like we're seeing, and that is the product of many years, and new government brings new programs over the years, and that generates funding for the different programs, and each government has its contribution into the complexities, and over the years the system is so complex that it makes it difficult to be managed. And so that is a calling to try and simplify our system and create a framework which is more harmonious, and it allows us to evaluate resources.
And at national level, we have this discussion of the per capita value and the participation of the different voices. And of course, we do have stakeholders both within the Ministry of Health in the different departments and beyond, and the majors and the health unions and different players that have their eyes on PHC. And I think that here we must work hard, because with this budget annual definition, I would say that we don't have enough participation in the definition of priorities. We don't have a formal process for assessment of health technology, so the coverage decisions are taken by officials within the administration, and we don't have a universal flow to compare the relative value of each of the components. And our funding system doesn't have a regular institutional costing analysis, because that would decide the per capita value. We do have an experience of costing in public policies. There is a regular costing there, but for primary health care, for our portfolio, we have this institutional manner, and this is something we must add in the primary health care reform. That is what I would mention about the lessons learned in our own reality. Thank you. Thank you, Bernardo. Well, we're looking at the universalization process of PHC in Chile. Do we have time to open for questions and then have a closure? I can't see you well because of the light, but maybe there is somebody. Thank you. I would like to start from this adjustment made by Federico regarding expenditure and investment in the primary level. That could be up to 40 and 50% in countries such as Brazil, Mexico, and others. However, I think that there is something that was mentioned earlier on, and that is that we have not yet reached a consensus regarding what institutions and persons understand when they speak of primary health care. Many of us continue speaking in general terms of PHC as a first level of care. And that could be a strong bias. And I think it's something that must be sorted out, because if not, it will become a never-ending discussion. I would like to add also, in relation to countries that have between 40 and 50% of the private expenditure, there, of course, there could be a balance between primary care and specialized care. But this doesn't take into account the fact that in those countries, the 50% that is private is mostly at hospital level, because the first level isn't usually business, with the exception of very few cases. So if we make that adjustment, we will, and again, with an insufficient primary health care. And to that, we must add the element of the definition of PHC. But I would like to end my question for Helen within the straitjackets for the public funding. One of the most frequent is a restraint to hire staff. And in the first level in the health system, we have intensive labor. So how can we increase the supply so that percentage of coverage doesn't face this 60% real access or less? There isn't any investment, and ultimately the countries that have that apparent significant proportion of PHC are those that are more distant from the 6% reference of the GDP. So in a context of disinvestment in health, it's hard to make those comparisons. Thank you, Julia. Well, we'll hear the three questions and then the panelists will answer. Good afternoon, Sergio Minuet from PAHO, the PHC unit. My greetings first to Federico. And I have a question regarding this constant that is cross-sectional in our forum, the three magic words: investment, innovation, and implementation. So we speak of innovation, we generally tend to speak of technology, and in that sense, telemedicine or telehealth is an innovation, indeed AI, but the human resources don't seem to be an innovation. And the technology that is most used in the first level of care in PHC is clearly the human resource. And indeed, Bernardo has mentioned it regarding some municipalities that reached up to 100% of the expenditure in human resources. It shouldn't be a handicap for investment in the first level of care that this technology is the human resource. I will give an example of an OECD country, that is Spain. In the Recovery and Resilience Funds in Spain due to the pandemic, they had monies for all sorts of technologies except human resource-based technologies. And a brief, naive question: why is it so hard to agree on the percentage required for PHC and the first level of care? And I say it because oftentimes we speak basically of pharmacy in PHC. And in OECD, they speak of ambulatory expenditure, including much more than primary health care. Thank you. What a question. Thank you. I have three items. First, I share Julio's concern about the definition of PHC. That must be clarified. In PAHO, we speak of comprehensive or integrated networks with a primary health approach. And then we ought to pick up what one of the organizers of MATA had said. It had been poorly translated. It is essential, not primary care, that is encompassed in this primary health care, encompassing this broad range of the human needs for health. Because if not, it's a community service, something you have there with few professionals for poor people, when indeed in the region we speak of a complex set of territorial responses, rehab hospitals, community hospitals that are close by with emergency departments and labs at a sustainable scale, with a certain volume, and in remote regions with a dispersed population will have a higher cost because we need to have them to have access, even if it's more expensive. That's the first key matter. And I think that we're speaking of integrated networks with a PHC or essential approach. So we must consider the whole range of responses and not mistake it for a first level with lower clinical capacity, more focused on prevention and so on. I think it's key to discuss it because it has a direct impact on the cost. We have no time. It's please wrap up. If I go fast, they won't understand. But I don't have time. I'm sorry. Second, regarding the economic aspects, Senka's from the human sciences reminded us it's a modal science. So we have to live well with finite resources. So the question isn't that we reach the finance people in government asking how much money is there, but tell them what is the standard we must reach for them to tell us where to obtain the money from. That's a different discussion, because if not, we would seem to have to adapt to the finance people's decision. So the social needs and the gaps and the social debt must be on the table. So we must have a scale of responses seeking a response at economic level. And then we must consider that strategic public investment in health at a scale may be a growth factor to extend the national economy. And for that, we must go beyond this idea of the current expenditure and speak of strategic investment for the country's development. If not, we'll always be under a very conservative management that states that expenditure must also be subject to the budget balance. I'm sorry, we have no time. 2 minutes for Federico and 2 for Helen. Just to wrap up. Who goes first? Briefly. There's an important measurement of what is considered primary health care or not. If we adopt a restrictive measurement, well, there are harmonizations. We don't have essential medication prescription included and things of the sort. And that is part of an important prevention approach. However, with a very broad definition, the risk is that everything will be included in primary health care. That is why I make that criticism. We don't include medication. Ambulatory is correct. But I think we need to have a clearer discussion about the items that are part of primary care. Because if not, we can't say we must invest more in primary health care. People will say we already invested 50% in OECD. The average is 16%, now 13% for primary care. Very, very little. As for innovation in human resources, I totally agree. And there are 2 elements. When I am in Europe, I give an example of major innovation in human resources and health, and that's community health agents. In England and in Central Europe, people think it's a major innovation, but in Latin America, it's advanced nursing practice, giving the nursing personnel the capacity of doing many things that only physicians are currently authorized to do. I agree totally with you that innovation isn't only technology. I could say more, but I would rather listen to Helen. Thank you. Thank you, Federico.
Yeah, sorry, I was trying to listen to the questions in Spanish, in French, and English, so there was some delays, so sorry about that. No, very important questions. I don't think I will come back to the issue of definition. I think and I hope that you will have another session actually on PhD definition. I know it's quite controversial also, but I think there is quite a lot to say. I think Federico has covered it, but I think it requires more discussion. At least just to mention the way I have used the term in my presentation it was related to the service part of PHC. So I was not covering the non-service part of PHC. As someone mentioned, there is also some community level services, some cross-sectoral interventions, nutrition, for example. So those components were not covered in my presentation. And the way I used the primary care service term was to cover the first level of care, but also potentially other levels of care. But as you said, sometimes they do also provide primary care services. District hospitals in the region provide primary care services in some instances. So that's how I use the term primary care services in my presentation instead of using PHC term, which is more an approach, okay? A lot of good questions. I wanted also to react to, if you allow me very quickly, Claudia, to 2 points that the panelists also mentioned during the panel. First thing that I wanted to reiterate is that, and that's also the reason why I thought this session was very interesting, is that it was mentioned by the 2 panelists. So PHC financing is not only about putting more money on the system. It's about the processes, so the PFM processes that we discuss here. I think this is very important to flag it because it's often not systematically recognized as an important driver for PHC financing effectiveness, right? PFM, as I think it was the colleague of from Chile who put it, PFM is often perceived as something very technical, very complex, not very sexy, right? I think you said that. This is true, but I think increasingly it should be understood as something very important to be recognized and considered if we want to have effective PHC financing. The last point very quickly that I wanted to make is that in my presentation, in the panel discussion, I think you understood that the discussions were very technical, right? We spoke about even the level of spending at subnational, all the processes at the municipal levels and so on. So PFM can appear very technical, but the point that I want to make is that PFM is also somehow non-technical in the sense that PFM is also extremely political. It's extremely political because it's about allocating resources to priorities. And then in that, there is a lot of powers, there is a lot of politics, there is a lot of dynamics between health and finance. And seriously, I think we need to recognize what those power dynamics much more explicitly if we want also to implement much more effective PFM reforms for PHC. So PFM is technical, but it's not only technical, it's really political, and we need to recognize that. Thanks a lot.
Thank you very much. And thank you very much to our panelists here, nuestros panelistas aquí, Bernardo, Miquellas, Federico, Helen. I apologize, James, Ernesto.
Bueno,
I would like to also congratulate all the panelists and the participants in this session. As you have seen, it can be transformed into a week-long event itself. That won't be happening. We will have to wish to continue. At 5 o'clock, we need to begin again, so we have about 10-12 minutes to have a brief break. We please, in 10-12 minutes, we hope you will join us. We have 2 sessions, half an hour each before ending, and we cannot delay this part of the event. So I beg you to return in 10-12 minutes. Thank you very much.
Bueno, buenas tardes, bienvenidos de vuelta.
Good afternoon. Welcome once again. It's not nice to be pressing you with time, but we're late. I'm a specialist in health financing from the PAHO regional office. It's lovely to be in my country with us. We'll have two brief half-hour sessions. The first, called Innovation and Solutions to Strengthen PHC, and this will be chaired by Mario Cruz, advisor in the Chile PAHO office. Thank you, Juan Pablo. Welcome, everybody, after this very short break. As mentioned, we'll have a very short session on innovation and solutions to advance in the strengthening of PHC. Our director, Gervas Barbosa da Silva, in his work platform as director for PAHO, included a pillar that motivates us to accelerate the inclusion of innovation and lessons learned from the pandemic in the health systems. As mentioned before, today, this isn't as fast as we would want it to. In the General Work Program for WHO 2020, the Director General created a special program on PHC that is geared to better articulate the work that our organization does to serve the countries and help towards the implementation of solutions, helping towards the transformation of the health systems and organization based on PHC. It's a pleasure to introduce Jam Sayed, Head of Policies and Partnerships in the Special PHC Program for WHO, responsible for the main presentation today that will then be commented on by Dr. Seduja, Director of the Latin American Perinatology Center, Women's and Reproductive Health in PAHO, and Felipe Proenzo, Director of Program of Primary Health Care of the Ministry of Health, Brazil. Shams, the President, the floor is yours.
Thank you so much, and if I could kindly have the slides, that would be great. Thank you. It's such a privilege to have this moment with you all and to be able to share a few things. I know it's been a really, really long day, but it's been such a privilege to listen to the expertise and wisdom within the room. In the 15 minutes that I have to be able to share some thoughts, one of the first things that I did want to bring to the table is the political nature of primary healthcare. And many of you will have followed the UN General Assembly high-level political declaration on primary healthcare. And even listening to the discussions this afternoon, we can see that it becomes a head of state issue when this becomes such a priority for us in totality. And we've heard this repeatedly being mentioned, and this is, in the words of our Director General, PHC is the most inclusive, equitable, cost-effective and efficient path to universal health coverage, and that's where the link with all of our work comes in. Just a few weeks after that, and Minister, you were there with us in Astana, our Director General put forward 3 priorities, which has resonance and clear alignment with everything that's been discussed today. First of all, concrete investment, bold political decision-making. Second, utilizing a mechanism to bring things together systematically through an operational framework for primary healthcare. But third, and perhaps bringing this in as an emphasis point, it's not just a technical issue. This is here, the human side of primary healthcare really needs to be taken into consideration. It's about compassion for our fellow human being in the final analysis. Now, it was really interesting just before the break to hear the discussions starting to shape up related to the 3 components of primary healthcare. Not to belabor the point, but just remembering these 3 words, the services, the empowerment, and the focus on multisectorality. So it's not just the level of care. We must focus in on the services, which include primary care and public health functions. We need to focus on the empowerment side and the multisectorality side. That's the challenge of our time. And really, again, not focusing in on the framework, but just thinking about all the discussions today have focused on some of those strategic levers that we can see, the politics around primary healthcare, the finance, the governance, and the engagement. But at the same time, thinking about those operational levers, those levers that are everyday business for those that are shaping primary healthcare and implementing primary healthcare. Issues such as systems for improving quality of care, health workforce issues, physical infrastructure issues, and all the models of care issues, and of course, something that's dear to many people in this room, the issues related to research and innovation. And importantly, to emphasize, and I know that this is going to be the work of the week that we have ahead of us, is ensuring that technical materials that have been developed, such as the PHC measurement framework and indicators, can be utilized in the work of countries. Monitoring health systems through a primary healthcare lens can really shine a light and focus for the future. What do we do with all of this? And this is where I'd like to focus in on for the remainder of this intervention. The focus on learning from implementation is so important to us. In Astana, we launched the first collection of implementation solutions based on the primary healthcare approach. This will be fully released in the coming weeks, but I wanted to make some points of emphasis related to this. First of all, the fact that 50+ country examples are placed within this PHC primer, that the evidence on those strategies within those operational levers can be taken forward, supporting health systems transition towards PHC models of integrated care. So the reason that I'm bringing this to your attention is that traditionally, PAHO has spearheaded the effort on primary healthcare. And through this alliance, there will be a lot of opportunities to share further information as we move forward. The importance of investment, of course, this is the primary purpose of this day. The Health Impact Investment Platform at the global level is fully aligned with the work of the Alliance for PHC in the Americas. And this global health impact investment platform includes the AFDB, EIB, IDB, ISDB, and the WHO. And of course, that you can see that the alignment and integration is clearly there. Both at a global level and at a country level, the coordination of efforts to ensure complementarity in technical assistance and funding, maximizing the impact of our collective efforts. But what is the focus of that health impact investment platform? And again, it comes back to the PHC approach, the three components that I mentioned, but also thinking through those strategic and operational levers for action. We won't have time to go into the detail of that, but we can see that there will be complementarity and exchange between efforts that will be spearheaded in the Americas with other efforts that might be spearheaded in other parts of the world. Getting a little bit more granular, and again, we won't have time to go into the details of this, but I did want to make sure that you were aware of the Primary Healthcare Global Health Initiatives Toolbox. This is a mechanism to ensure that grants, that projects that are focusing in on primary healthcare, supported by global health initiatives, can align and have maximal impact on the populations that we serve. I would love to strike up any conversations in the coming days to make sure that this is made fully available for any of the country-focused efforts that you have ongoing. The added value of this is that when projects, proposals are developed, they can start to use the PHC logic and approach to take things forward in a systematic and comprehensive way. I did want to come to a specific issue related to quality of care. As many of you in this room recognize, quality of care is such a critically important area for the populations that we serve. It's one of the levers within the operational levers that I've mentioned, systems for improving quality of care. The work of the Lancet Commission back in 2018, for the first time, provided estimates that allowed us to recognize that access and quality are equally important, and that access without quality is not giving us the results that we would like. So performance and ultimately human lives are suffering. And this is where the integration of specific populations, a lot of the work on quality of care has focused in on maternal mortality, has focused in on infant mortality, has focused in on issues related to HIV, TB, malaria in other parts of the world. And this is where the bridges can be brought together in a substantive way. Those systems for improving quality of care require national level strategic direction setting. They require sub-national level efforts, but they also require efforts at the facility level and at the community level. This is where that comprehensive approach to systems for improving quality of care can be blended with the different levers, because you can't talk about quality without talking about strategic purchasing, without talking about health workforce, without talking about physical infrastructure. Resources are available, and again, in the next few days, I'd love to strike up a conversation related to the resources that have been made available by PAHO and WHO in that regard. But leveraging innovations for meeting country PHC-related needs. Now, again, this is a whole day of conversation around innovation and embedding innovations, but starting with identifying the needs, sourcing and assessing appropriate innovations, matchmaking needs with innovations, designing the implementation and governance, and tracking that implementation. Innovations can be kind of sexy, but actually the tracking and making sure that that's tracked right to the end within a systems-based approach is key. And one particular area that I think where we would like to excel is to make sure that learning from countries across the world exchange. So this is an example of learning from Brazil that made its way all the way to North Wales related to primary healthcare workers. These are examples that should be at the forefront of our global health endeavors because learning has no barriers, south to north, north to south, and south to south. We also heard about essential public health functions. It's really critical for us whenever we're talking about primary healthcare to make sure that the primary care element is linked clearly with the public health functions. Now, we've heard that throughout the day, and what's important for us to remember is that the body of work associated with this is evolving. The conceptualization of this has been led in many ways by PAHO, and there are many ways of bringing that wisdom of regional colleagues together in various fora. This is something that we need to actively explore, and I would urge us to think that through in the coming days. A reference list of EPHFs responsive to the 21st century challenges that we heard about from the senior leadership this morning is clearly something that we need to tackle head on if we're going to be prepared for further public health emergencies of international concern, but also if we're going to be focusing in on health promotion and prevention, the key of essential public health functions that are linked to primary care. I know that time is incredibly short, but again, we know that without country presence, it's very hard for us to move the work. And this is where we have within the PAHO WHO family that country presence at country office level. And this is where the real work lies. But the linkage between those health policy advisors in all of the countries is critical. And this is where the cross-regional effort, because there may be a solution in Senegal or there may be a solution in Malaysia that needs to be taken on board in an effort somewhere in the Americas. Time, as I've been instructed, is short, but I did want to take 2 minutes actually on this slide. With all of the technical discussions on primary healthcare, sometimes we forget the fundamental aspects of primary healthcare, which are the PHC values: health for all, community orientation, equity, solidarity, social justice, and people-centeredness. Now, PAHO and the Americas has led this effort in terms of values of primary healthcare. It's been a fundamental way of working, and I've had the privilege of starting my WHO career in the Caribbean with our PAHO colleagues. And I've always remembered the specific drive on values, but also the specific drive on people and human beings. This is another part of the PHC equation that we should always remember, particularly thinking about compassion when we're thinking about the suffering of fellow human beings and action to alleviate that suffering. PHC offers us an opportunity to do that. I wanted to be respectful of your time, and thank you for allowing me this moment.
Thank you, Shams, for reminding us the principles of primary healthcare and also for giving us some elements regarding the question that we had before about the definition of primary health care, as you also shared the important frameworks and good practices to advance in innovation in primary health care. Now I'd like to invite Suzanne so she can give us some feedback comments. Good afternoon, everyone, Minister. I am the director of the Latin American Perinatology Center, and I'm going to speak from this perspective. I have a few photos because I think at 5 o'clock in the afternoon everyone's going to be exhausted to listening to me, and a photo is worth more than 1,000 words. So I want to firstly thank the person who brought us today a good summary of these values that we have at the CLAP. And when we look at where we come from and where we're going, we want to give a quality care and humanized care, and especially a type of healthcare that allows the women and babies, but they're very small, their autodetermination, self-determination. So I want to tell you a few things that we think that translates what was initially spoken by Shams. We need to be effective. We need to be effective, and there needs to be equality. And this is the coordinator of Peru is here. This is a photo of one of the places we have one of the most important bottlenecks between primary care and the specialist. And so here we have a very interesting experience. I can't go into great detail, but just think of that image of women who are in their own place and they receive healthcare, specialist healthcare through telemedicine, and it gets them. This is an image of a woman looking at a mobile phone, but she is actually in the doctor's office. And so here we took the advantage of the pandemic and saw it as an opportunity to bring a specialist to the woman. And some of the interesting things that we have developed, and it was developed very quickly over the pandemic, which was, for example, these apps. Many of you, I'm sure, have children. Some of you may even have grandchildren. But you know that the first 28 days are challenging. When I had my daughter, I thought, why didn't she bring an instruction booklet to tell me what it needs to do? This is a manual for the first 28 days. It's in the 4 official languages, it's free, and it has information for the woman, the mother, and for healthcare providers. And that's why it's important, because it becomes accessible. All these things that we write about, but we bring the participation and we bring empowerment to these women, giving them the knowledge, and that's very important for them to be self-determining. What's a rotafolio? We do this electronic ones. This is adapted to the culture. It doesn't answer to all contexts, but in each places it has been adapted. And in this image here we have our minister, and saying Uruguay is the first country which has a complete SIP Plus, which is the informatics system for perinatal informatics system. And this deserves a round of applause because it uses an informatics system for the mother and the child, and it is published transparently, and it has its results on its page. And having transparent information which is visible and available is very important. We have also lots of different training programs of the median and high fidelity, and also we have these technologies for CLAP which have been used for many years and has allowed us to do something that I want to show you. It's related to what Sham said. What's the most important things when we see infant and maternal mortality? we're not lowering it, because when the services aren't offering quality care and they're not centered in the women, or they're not thought for a person, they're often thought as problems. There's a problem with blood, or there's a problem with the ambulances. They're not thought through the lens of the woman's life, who's living in a specific place and needs a specific type of care and may need to be transferred from one place to another. So something that I saw and noticed is that we know that the importance of a cooperative approach between countries is for countries to stay on track. It's to try and make those countries able to track their progress and monitor and be accountable and improve the quality of care. And in this case, it would be for women to have access to the services. Often there is a delay in the most vulnerable women reaching the level of care that they need, but most of maternal deaths take place in our healthcare providers and centres, and this is an issue that we need to consider. It's a social justice issue, and it's something that we all should advocate for. We've spoken a lot about this today, about maternal death, and this care needs to reach each woman that needs it, especially those who are the most vulnerable. So I want to thank you greatly. Dr. Shams, your presentation, you brought these concepts that we think are the most important ones. And so I really liked what you said, that we know that all the innovation, everything that we can prepare doesn't necessarily translate if we don't have that human side to it all. Thank you.
Muchas gracias, Susan.
Thank you, Susan, for reminding us several of these examples of the most recent innovations in our office, and also reminding us the challenges of quality and the importance of humanizing and having people at the center of primary health care. Now I'm going to invite Felipe to give us his feedback. Good afternoon, everyone. I'm going to give a presentation on the principles that have been presented. Were aligned with what we've been developing in Brazil. In this short time, I want to relate these principles with the priorities that are being developed in the single healthcare system in Brazil. This has been a political choice, and a choice that is essential in a country such as Brazil, which has many inequalities, and the inequalities have increased in the last 8 years. So we believe that the path of primary health care is the path which will give us results, and it will manage to work with different populations, especially those with a high vulnerability in many places in Brazil. For this reason, this universal system in Brazil with public health care, which we've been working in regards to healthcare, the right to access healthcare, and believing it as a right for everyone. It's also hand in hand with primary health care. So these principles presented by Shams have been directly related with what's been guiding our system in Brazil. In this sense, what I'd like to present in my session is three innovations that have been developed and implemented in the Brazilian health system, and they also are related to a fourth innovation that we've been doing. And we'll talk about digital health tomorrow, so we won't go into that one so much. So I'll focus on the first 3 points we've been working on in Brazil related to healthcare. One is related to the role of primary healthcare in Brazil. There are 52,000 teams in 5,000 municipalities in Brazil, and they have a doctor, a nurse, and a community agent. And we want to increase this number of teams, so we will be able to have a larger number of people who will have a primary healthcare team close by to them. And also have community workers who will be rare, where we will see the importance of the participation of the team. And also the presence of a team close to the patients. It's going to be important and strengthened, and that way will be at the center of this public discussion in Brazil. We are investing in teams which are multidisciplinary teams and considering family medicine and community medicine, including a doctor and nurses and a community agent, and we'll have teams that will also have psychologists and nutritionists and physiotherapists and specific specialties within medicine. And those specialties will also support and increase the reach of this family care healthcare team, and they will also establish a dialogue with a specialist team. And these teams, therefore, have been picked up again and reconsidered in Brazil, and there's been more investment in this to guarantee access, but also guarantee quality, because we are talking about a universal system. It is a team that's going to have healthcare, family healthcare teams, which will reach 76% of the Brazilian population, with these initiatives of dispensing teams and increasing primary healthcare. And we believe that we are walking in the correct direction and innovation in primary healthcare. Another point which we are working and developing at this time, which also has an important role, is what's related to continuous training and continuous education, which is important for developing strong healthcare systems. And this is also related to innovation with access and quality in the Brazilian healthcare system. To give visibility to this and make it something concrete, we're working on the strengthening of primary healthcare system and the investment from $6.3 to $8.6 billion to be able to strengthen this system in Brazil and be an important thing in the Brazilian politics. And from the system, we're also working in a greater investment in structures and equipment of these basic teams. We're working from different experiences, what we've been saying over these days and looking at these presentations about the principles. We hope to continue to evolve, and we continue to work with primary healthcare at the center of the Brazilian system, and therefore have new results which we'll present in the next couple of years.
Muchas gracias, Felipe. Justo en la sesión.
Thank you, Felipe. In the last sessions, we talked about the importance of innovation in human resources, and what you've been sharing about Brazil gives us good examples of this. Congratulations for the impulse that primary healthcare has been receiving in Brazil, and it's always been an example for us in a region. We're coming to the end of our session, and I just want to highlight Sam's presentation and everything that was shared by Suzanne and Felipe. I want to thank you all for this presentation, and now hand the floor over to my colleague Juan Pablo with the program for this afternoon.
Muchas gracias, Mario. La verdad que te ganaste el premio al mejor moderador.
Well done, Mario. You've been a great moderator. Now we're going to give word to Vascolo, who will coordinate this next session, which will be brief but very important. and a new commission of Lancet America between the WHO and the World Bank, strengthening Latin America and the Caribbean. I will try to be quick because my colleagues are going to help me with that. I think that during the whole day today it's been very intense and very enriching during all the presentations, but primary healthcare, it's not been presented in a abstract idea, but more as the inequalities in the different systems and difficulties in access. But we also need to consider one of the issues that has been a center axis, especially in this morning's sessions regarding resilience, and we need to consider the role of primary healthcare and resilience, especially, and reflecting on not only theoretical aspects but also on actions which need to be included in the context of action in the primary healthcare setting. Despite all the innovation advances that have been recognized in many other countries, that we've heard their experiences today, and we will continue to hear from them in the next few days, there is also a great need to understand how implementing a healthcare system based on the primary healthcare system to transform and prevent and prepare, respond and adapt in a adequate manner to different situations.
By this, I don't only mean public health. Natural disasters, climate change, that is so relevant. And conflicts and violence that weigh greatly in the region. It is in this framework that the World Bank and PAHO create a Lancet Commission on PHC and resilience in Latin America that will seek to advance in the knowledge to inform decision-making in the future development of PHC and resilience in the region. And we believe that this knowledge and experience is very fundamental. Producing new knowledge is key to achieve these goals. The Commission will try to develop a comprehensive political, operational, analytical framework for primary care and resilience, identifying fundamental strategies and policies that will develop and define key investments that the countries of Latin America might use, with a rigorous assessment of the foreseeable consequences if we were not to construct this resilience in PHC in the Latin American countries. As part of this panel, this short panel, we will tell you about this in a video by Sabila, chief editor in the regional Lancet for the Americas. So, if possible, let's see if the video can be seen.
And the Caribbean. This commission is set out in a fortunate moment as we recover from COVID-19 pandemic that not only disrupted our health systems but also exposed their fragility and unpreparedness. It is now more than ever very clear that we do not only need to achieve universal health coverage, but it has to be one that's based on primary health care approach, and it has to set up a foundation of resilient health systems and societies that can guarantee quality health care for all. As you may know or may not know, the Lancet was founded in 1823 by Thomas Walkley, who was a surgeon, And it was set up with the vision that it should be more than a medical journal. It should drive social and political change through advancing medical research and science for the greater good. Fast forward to 2023, The Lancet is now a family of 24 journals, but we remain committed in improving lives through medical research. The Lancet Regional Health Americas is part of the Lancet Regional Health Global Initiative to advocate for healthcare quality and access in all regions of the globe. Our goal is to improve health outcomes by fostering the advancement of research agenda, clinical practice, and health policy through a regional lens. And therefore, this is why I am thrilled to support this commission, and its set goals are perfectly aligned with our journal's mission to advocate for change in clinical practice and health policy in the Americas. I truly hope that this project will result in a reference report to support and guide the future development of primary healthcare resilience in Latin America and Caribbean countries. I am very sorry that I cannot be here today with you in person for this very rich discussion that you're set up to have, but I hope I can join you in the next ones. Thank you very much and enjoy the discussion.
Okay. Thank you, Taisa. Sorry she couldn't be here with us. And now I invite two colleagues from the Commission, Adriano Masuda. Please. He is professor at the Getúlio Vargas Foundation. Is he here? Yes. And he's coming. And coordinator for the Health Planning and Management Center. He has an MA and PhD in health policies and planning at the Campinas University. He also worked as Undersecretary at the Ministry of Health, Municipal Secretary for Health in Curitiba, and National Science and Technology and Strategic Input Secretary at the Health Ministry. And also invite my other colleague, Christian Herrera, a senior specialist in health in the Americas and Caribbean. In the Global Health Practice, Nutrition and Population World Bank, has been an analyst of health policy. It is an OECD and high official in the Ministry of Health in Chile. He's a physician. He has an MBA, an MA in public policies, and is a candidate for a PhD in health services. We have little time. Let's do our best. They will help me. I hand the floor to Christian Herrera. Good afternoon. Thank you for staying on. It's late. I especially thank the Minister for being with us, knowing that she has a very tight agenda. So, briefly, we are very happy for having created this partnership among the World Bank, PAHO, and Lancet, trying to gather the pros of each of our organizations. Briefly, I'll tell you in general terms what this is all about and what we'll be doing. We mentioned it throughout. It is broadly acknowledged that PHC is extremely relative. This has been repeated during long years, and this commission supports this. However, its use has been variable. And what we observed in the pandemic was an example. In many countries, the focus was at the hospital level. It could be justified for many reasons. Of course, lives were saved because of this. But in turn, PHC was underused. And this is something we must really analyze. So this is a basis of what we have. And in turn, this has led us to say that resilience has become a feature that has come up in the agenda when discussing what is necessary in the health systems. And indeed, because this was so broadly studied, there are knowledge gaps, particularly in PHC and furthermore in Latin America and the Caribbean. So we are giving the different specifications. Ernesto also mentioned it. The Commission has 3 general goals. One, to generate this conceptual policy framework on PHC and resilience towards the health system with this health system approach. The idea is to use the whole resilience system from prevention, passing through preparation, response, and adaptation, the whole resilience cycle, to tackle different public health emergency risks. So we have climate change, risk for pandemics, demographic shocks, for example, migrations, violence, and conflict, among others. We expect to then aim towards the identification of strategies, policies, and investment that the countries in the region may carry forward. And last, estimate the possible consequences of not building this resilience. Perhaps this is a major technical challenge to generate scenarios with and without strengthening of resilience. And Adriano and our colleague Sarah Bannett are the academic people helping us to generate this. We fully trust them. But at technical and methodological level, this is a great challenge. So this is a coordinating team. We call it the core team for the World Bank. My colleague Manuela Millar and myself, and then for PAHO, Ernesto, you know him well, together with Natalia Horton. So the 2 international agencies are present, and the academic chairs, Adriano here and Sarah Bannett from Johns Hopkins University. Maybe some of you know her. And then we'll call for the Commission to have experts and decision makers of civil society representing technical areas. We want it to be gender equal, covering all the sub-regions. That is representative for the Latin American Caribbean region. And that is where we're currently working. The timeline, this is the announcement for the Commission. What we're doing now, we'll launch the Commission, including the different commissioners, with detail of the progress, technical level, and throughout 2024 we'll generate technical work. We hope that the report will be published in the first 6 months of 2025. Lancet is a scientific journal with peer review. That is our estimate. So we hope to have some associated publications, thematic papers on climate change, PHC and resilience, country studies. So if anybody is interested, maybe we could have a deeper analysis and even pass on to how to do this, but not only what, and the consequences and the how. Events with a dialogue involving different players and dissemination in general terms. This was published in the Lancet Americas announcing the Commission. You may find it. And last, this website of the Commission that will update, but that is already functioning and states what I just told you. Thank you. I think I was on time. Wonderful. Well, to be more efficient, I'll hand the floor now to Adriano. Let's see who wins the award for the best panel. Good afternoon, nearly good evening.
I'd like to thank you for the invitation. I will speak in Portuguese because we've been working with the different languages, and you're aware there are many Brazilians with us today, and the Secretary at the Ministry of Health, Isabella, Felipe, the Secretary of Primary Health Care. I had the opportunity of, after living the development of the healthcare system as a municipal Secretary of Health for Curitiba in the state of Paraná, and also in a federal level in the Ministry of Health. I was Secretary of in strategic and technology in the Ministry of Health. After 6 years of experience in the development of the universal system in Brazil, I spent 3 years studying healthcare systems in the University of Harvard, along with Professor Marcia Castro. And at that time, we were trying to analyze the advances and the challenges of the implementation of a universal system in Brazil. We have after nearly 30 years of experience, and at the point when we began that study, it was a time in which the country was living in an important political and economic crisis, and that there was they had recently adopted certain austerity measures, and so the resources were negatively impacted for healthcare. At that point in 2016, I was trying to get references and examples of resilience and analyzing the system and the healthcare system. And we saw an important production which was developed in European countries, and we analysed the impact of economic crisis and austerity measures in the healthcare system. And the impacts were alarming. We saw they were worsening in healthcare indicators, and it was quite quick to see that deterioration. And if the European country that was happening in Europe, such as Greece, Portugal, Spain, imagine what could happen in the Latin American context, in which our countries will have fragile systems and social security system, which is what the healthcare system is based on, and there's a great fragmentation of the system, a great inequalities in coverage, and also there was a need to try and adapt these models for our context, a Latin American context, and understand the impact of this crisis in Brazil. Sadly, there was a certain story that developed with this economic crisis and fiscal austerity measures. There was an impact, and then we had the pandemic in a country which was ruled by the extreme right-wing parties. And so that had catastrophic effects on the system and in the healthcare situation in Brazil. And this got worsened very quickly, and when I was the Secretary of Health in Curitiba, we tried to have 95% vaccine coverage, and it was something that we thought we could do easily. It was already a system that was working. Vaccines wasn't something that needed to be worried about. We could worry about other things. Vaccines wasn't one of those things. and we wanted to work on heart disease and other things. But we took several steps backwards in a very short period of time. And this Lancet Commission comes at an important time for our region in Latin America. It's a time in which we are facing political challenges and healthcare systems which are they need to discuss what primary healthcare is, what model we need, how do we finance it, how do we fund it, because primary healthcare can no longer be seen as a vertical program to work on poor people's problems. It needs to be directed specifically to the most vulnerable populations, but it also needs to be the basis and the structural base of a universal healthcare system. Without that, it isn't primary healthcare. Without that, we cannot have the development that we need of a system, our region, a system that will actually allow the region to grow and develop and generate and work on the great inequalities that we face in our region. So without doubt, this Lancet Commission, I think it's an opportunity without comparison for our region to study the experiences that are in this country, and the advances and the challenges and the setbacks. But it is also necessary to promote a transformation of this system in our region in a way that it will generate improvement in a social, economic and environmentally friendly way. Brazil had changes in governance, and it's a unique opportunity. And there are certain challenges to develop universal healthcare systems and socio-economic differences, which is our region. For a more political stance on this, my role here is the academic role, which I have, and I am proud of being with Sala Bennett, and the experts are extremely valuable in our region. Our region has a lot to develop in analysis and developing our systems, and the experience, a European experience to change the systems is something which we hope to be directed at, but we want to bring to the Latin American reality. We need to think about case studies of our reality and our context to together develop innovations which can be an example for the world, as was the strategy of family health in Brazil. It isn't just the community agent in Brazil. The innovation is a multidisciplinary team in which the community agent is part of a team. And many countries have done this, but to work in a multidisciplinary team, to work with a population which is going to mix with collective health and educational activities was the base of this system. And it is a system that was developed based on the Brazilian context and the socio-economical context, and implementing primary healthcare in Brazil. It was a strategy to extend and implement a universal healthcare system in Brazil, and this reform of the healthcare system and of healthcare in Brazil. It's a civilizing way, and it was a framework and in our national conference that gave us the strength to implement a universal system of health like the system that we currently have, creating the basis for a strong primary healthcare system which is resilient and including this health for the family. It isn't an easy task or easy feat, but it is an opportunity, and having the World Bank on the one hand and the WHO and PAHU on the other side, it's also an unique opportunity for our region to develop a system which is strong, resilient, and has primary health care as the basis and at the core. Thank you very much.
Son estos minutos que uno entra en el dilema o en la
So I want to be the best moderator of the day, but extend the discussion throughout the night. But I will try to save the face this way. Firstly, I want to recognize and thank and congratulate my colleague, Cristian Herrera. He not only is a part of this initiative, who's been guiding and has been propulsing the idea. It needs to be recognized publicly. And Adriano, I thank you greatly, not only for your contributions on the academic, your analysis of the context. I'd say I'd go a step further, but there's that political component, which is your testimony of your country's experience. So I want to thank you. And also thank all of you. You've been here for more than 10 hours. We will see each other again tomorrow. And I'll hand over to my colleague, Juan Pablo.
Otra señal, pueden ser más directos y apagarnos la luz. Muchas gracias, Ernesto. El premio al mejor moderador lo retuvo Mario, lamentablemente, pero al final de los 3 días vamos a oficialmente anunciar el ganador al mejor moderador, así que sirva de incentivo para el resto de los moderadores. Bien, antes de algunos anuncios un poco logísticos sobre la recepción que el gobierno uruguayo nos está invitando en Cancillería, quisiera tomarme 5 minutos para hacer 3 puntos que por lo menos me llevo yo de lo que ha sido el día de hoy, que fue muy importante para nosotros. Uno podría ser un poco cínico con todo esto, ¿no? Uno podría decir, bueno, estamos hablando de APS, Atención Primaria de la Salud, Alma Ata, 78, y estamos acá en Uruguay otra vez explicándonos qué es la APS, por qué hay que invertir, qué han hecho los países, qué está pasando. Yo creo que no deberíamos, o por lo menos no nos podemos permitir ser cínicos al respecto. Yo creo que los países han avanzado mucho desde el 78 a esta parte en temas relacionados con la APS. Evidentemente, como son estos temas de políticas públicas, en salud en particular o en general, hay avances y hay retrocesos. Pero es innegable que los países no es que se durmieron una siesta en el año 1978 y hoy estamos acá despertándonos a discutir de nuevo estos temas. Entonces, al respecto vimos experiencias muy importantes de nuestro país anfitrión, que tuvimos el lujazo de tener a la señora ministra acompañándonos todo el día, lo cual agradecemos mucho. Tuvimos ejemplos de Uruguay, procesos de reforma muy actuales en Colombia, en Perú, Brasil, Paraguay, Chile. Es decir, demostraciones concretas de que países han hecho avances significativos en la implementación de esta estrategia de APS y no solamente de fortalecer un nivel de atención. Entonces ese es el primer mensaje que quiero dejar. Los países han avanzado y se han hecho cosas. Segundo punto, y nos concierne un poco a nosotros, es que los países no pueden solos. No pueden solos, evidentemente es algo de lo que nos trasladan a nosotros, pero lo importante es que no están solos, justamente. No pueden solos y no están solos. Nos tienen a nosotros, a los socios, tanto a los financistas, podemos decir, como a los cooperadores técnicos, que escuchamos sus requerimientos de que, entre otras cosas, nos coordinemos mejor. Nosotros entendemos que a veces esa segmentación y fragmentación que nosotros en buen romance les criticamos en su país, a veces las reproducimos nosotros en nuestro accionar con el resto de los socios. Entonces nosotros escuchamos esos requerimientos y uno de los principales motivos de esta reunión es venir a presentarles esta propuesta que nosotros tenemos concreta de coordinarnos mejor entre las instituciones que conforman esta alianza, con elementos concretos que evidentemente vamos a ir desarrollando a medida que pase el tiempo. Pero no es solamente un llamado a hablémonos un poco más, tomá mi WhatsApp, sino que formalmente estamos lanzando institucionalmente mecanismos específicos para trabajar conjuntamente en elementos concretos en los países. Entonces ahí tomamos nota además de la lista de Papá Noel que la ministra nos pasaba, y vamos a seguir tomando nota durante estos 3 días de requerimientos concretos que los países soliciten de los socios en apoyarlos en avanzar en esta agenda. Entonces tomamos nota. El tercer punto
The third point that is closer to my specialty, that is related to investment. During these days, we'll have these 3 words: investment, innovation, and implementation. Today, you'll have observed that we focused a bit more on the first I for investment, not because we think it's the most important or the only one, but because we acknowledge it's important to invest more and better. Some specific comments. What does it mean to invest in a resolutive PHC approach? More resources in the old manner of PHC that didn't solve the issues of the communities. Of course, we're speaking of an approach where PHC in the first level of care coordinate in integrated health system networks, including the hospitals. So it isn't PHC versus hospitals or taking away from hospitals, but acknowledging that PHC and first level of care are 2 different things, and accepting that strengthening the first level of care as such is an essential pillar in a PHC approach. We can't speak of PHC and say that because it isn't a level of care, everything will go to tertiary care. We don't invest in promotion and prevention because PHC is everything. Of course, it's cross-sectional, but the first level of care must be strong. And that's the first component for investment. Second, inequalities. This arose throughout. Latin America and the Caribbean is the leader in football, but unfortunately also the most unequal region in the world. So any investment strategy that doesn't take into account and tackle these inequalities that are the hurdles for access to the health service in the country are a hurdle. So we must tackle this and want the resources to reach the most needy communities. And third, regarding investment, bearing in mind that the hurdles faced by people to access the health services vary according to context, not only economic, not only paying from the pocket or the lack of technology or facilities. There are many more matters regarding with social acceptability, having the services where the people live, and not only purchasing more technology or investing more, ensuring that the services are free of charge in the point of care. And leading on to tomorrow, something that also arose and now focused on investment. We don't think it's the only one, of course, but people mentioned the need for strengthening the dialogue between the health and finance sectors in countries, but among countries and only among partners. And in this regard, in PAHO, and I won't make a list of the cooperation activities we have together with the banks, but if we don't reach with the necessary message, if we don't speak the same language, and clearly if we don't have local partners that ultimately define how the public budget will be used, we won't advance at the necessary speed. And on Wednesday, I wanted to tell you, we'll have a parallel event, and among other initiatives, we'll have an information session about this initiative that, together with the people from the State Department of the U.S., is called Economic Health Dialogue in the Americas. And we have specific lines of work where we're
having this dialogue to have specific agreements to progress in different lines of work with the health and economy sectors in the countries. And Uruguay is a technical leaders together with Paraguay. And you'll have further details on Wednesday. It's by invitation because it's a small event, but you may have received this email. And last, the Uruguay government kindly invites us to a party at the Foreign Affairs Ministry. It's a beautiful building. It's nice. And we'll have a tango show there, if I heard well. So the people from Pajo, and I'm not looking at anybody, hope you know how to dance, maybe. And we would have some chivitos for dinner. I don't know if that's confirmed, but anyhow, the buses will leave from the Radisson Hotel at 7. If you want to take a walk, and this is a personal proposal, you can walk through 18 de Julio. It's 10 blocks. 18 de Julio 1187. If you go through this main street, 10 blocks, you'll have time enough. If not, you take the bus, leaving the hotel at 7. And please carry your ID, because it's a Foreign Affairs Ministry, so to enter, you'll be asked to show it. Thank you. See you tomorrow.
Bueno, bastante bien. Además, especialmente este horario, la verdad que no es lo mismo.
La verdad. Y bueno, me sorprendí a mí misma con mi capacidad para el portugués. Normalmente me tranco.
Sí, yo no me ofrecí porque no me consideraba, viste, que podía mejorar. Pero me sorprende que no haya relay, porque hablando 3 lenguas, viste.
Sí. Debería de haber.
Porque a mí me pasa con el francés, que pasar del francés al inglés tampoco me es tan fácil como... Eso, son como neuronas, ¿no? Que no las tengo muy...
No, porque uno no lo hace tan seguido.
Sí.
Bueno,
linda. Yo mañana creo que trabajo con Delia.
Vos estás con Delia
Sí.
mañana, yo estoy con María Julia en la otra sala.
Ahí está.
A partir de 10:30. Ustedes arrancan la sesión de la mañana.
Bueno, yo ya no tengo perro, así que no tengo perro, que lo tengo no, lo tengo, lo mandé.
Ay, me asusté, dije, ¿qué le pasó?
No. Pero ¿sabes qué es? Vas a ver como cuando tengas hijos y tenés, que es como, yo digo, si no me da tanto trabajo. Y hoy, por ejemplo, que vine tarde, pues perfectamente. Lo que pasa es que ya le había dejado ayer, no le iba a llamar a la señora, él se me lo llevo y se lo traigo mañana. Pero es como algo que te libera y es como que te sentís como que tenés mucho más espacio. Cuando en realidad es tiempo de comer, sacarlo al patio y dar la vuelta a la manzana.
Ay,
¿no? Como que
sí, claro.
no pica nada. Una amiga me invitó a comer empanadas sin gluten esta noche.
Ay, qué amorosa.
Así que tengo planes.
Tenés planes.
Igual nos estamos viendo. Te dije que no te vi.
Nos vemos. Es verdad, estabas traduciendo con ella.
Bueno, chicas, a domani.
No había relay.
Se ríe y se sigue escuchando el original.
Nos tienen que mostrar después.
Sí, eso es. Eso hice. Se sigue escuchando el original.
Mañana 10:30, ¿no? Las que son grupo 2.
Sí,
son grupo 2. 10:30 está
¿Qué descanso?
¿Vos sos grupo 2 o grupo 1?
Mañana 1. Yo soy allá.
Vos.